Tim Geller, the Chief Executive of the Celiac Disease Foundation, and it is my pleasure to welcome you to the 2021 Patient Education and Advocacy Summit. With more than 1,500 participants from around the globe, today promises to be a milestone in celiac disease history. You will hear from the world's leading researchers and our congressional representatives who support them, as together we join to assure that our federal government recognizes the seriousness of celiac disease and that we pave a path forward for new treatments and a cure. A big thank you to you for dedicating your time today, to our speakers, our panelists, to the Patient-Centered Outcomes Research Institute for their Engagement Award to convene patients, and to our sponsors, Prevention Bio, 9 Meters Biopharma, Takeda, Anyos Bio, Immunogenics, Glutenostics, SHAR, Cabinet Health, and LabCorp for their deeply appreciated support. Celiac disease is one of the world's most prevalent genetic autoimmune diseases, affecting 1 in 100 people worldwide, the majority of whom are undiagnosed. Causing the body to attack its own small intestine, celiac disease often leads to many other devastating health conditions, including cancer, and results in extraordinary economic and productivity costs to both the public and private sectors from employee and student absenteeism, as well as repeated inconclusive visits to healthcare providers. Unfortunately for the millions who suffer, celiac disease has largely been ignored by our federal government, which provides little to no funding for research, nor for public awareness of its serious consequences. Founded in 1990, the Celiac Disease Foundation is the nation's leading patient advocacy organization dedicated to accelerating the diagnosis and treatment of celiac disease. Through strategic investments in research, advocacy, and education, the Celiac Disease Foundation seeks to improve the quality of life of the more than 3 million individuals in the United States affected by this chronic immune-mediated disease. Hosting the iCure Celiac Patient Registry and offering robust patient recruitment services, the Celiac Disease Foundation, in partnership with our patient community, speeds trial enrollment and improves retention to drive discoveries that may lead to better treatments and ultimately the cure. Since our founding in 1990, the Celiac Disease Foundation has played a key role in achieving federal recognition of celiac disease, improving diagnostic tools, and accelerating research for better treatments and a cure. The foundation convened and hosted the 1998 serology workshop, leading to the development of the celiac disease TTG-IgA blood test. Served on the 2004 National Institutes of Health Consensus Development Conference on Celiac Disease Planning Committee, leading to federal recognition of celiac disease as a common disease in adults and children, not a rare pediatric disease. Convened the American Celiac Disease Alliance, with lobbying efforts resulting in the 2014 FDA gluten-free labeling rule. Developed the nation's only celiac disease patient registry, iCure Celiac, and the iQualify Celiac patient recruitment screening and call center platform. Provided 2019 testimony to the House Appropriations Subcommittee and worked to secure fiscal year 2020 and fiscal year 2021 budget report language directing NIH to study celiac disease. Provided testimony to the 2020 NIH Autoimmune Diseases Coordinating Committee on the need for focused research on celiac disease as proof of concept for treating other autoimmune diseases, resulting in an invitation to join in 2021 as a committee member. And on March 18th and 19th of this year, we'll be presenting the patient view at the first ever NIH Accelerating Progress in Celiac Disease workshop.
I'm Edwin Liu with the Colorado Center for Celiac Disease. I'm going to talk about the epidemiology part of celiac disease. And so we know it's common, right? And it's seen in every continent around the world with a prevalence rate of over 1%, typically, with a pooled prevalence rate worldwide of about 1.4%. And we also know that as an autoimmune disease, it's on the rise, just like other autoimmune diseases like type 1 diabetes and multiple sclerosis. The thing is, it's not just these things that are becoming more and more frequent over the decades. Other immune-mediated diseases, such as Crohn's disease and asthma, are also on the rise. And so why are these things becoming more common over time? You know, I mean, is it the hygiene hypothesis, or for celiac disease specifically, could it be the role of gluten? You know, the hygiene hypothesis is that sort of like our environment just becoming cleaner and cleaner, so that the immune system has less to do, and it has, otherwise it just starts causing trouble. And so one thing we notice is that there's a decrease in the incidence of sort of like major infectious diseases that have been occurring at the same time that the immune-mediated diseases and autoimmunity, like celiac disease, are on the rise. So maybe the hygiene hypothesis plays a role. On the other hand, we do know that there's certainly going to be a role of gluten, but exactly how, we're not sure. So for example, the Swedish epidemic that took place for celiac disease in the 80s and 90s seemed to link factors surrounding gluten introduction to the onset of celiac disease in kids under age 2. So, you know, I'm just going to give you a brief introduction of like these two birth cohort studies called DAISY and TEDDY. DAISY stands for Diabetes Autoimmunity Study of the Young, and TEDDY stands for the Environmental Determinants of Diabetes in the Young. And these are birth cohort studies that follow children who have a genetic risk for celiac disease. And being in a cohort study like DAISY or TEDDY, I always say it's like being under a microscope for the first 15 years of life. And the purpose of these studies is really to search for environmental triggers for celiac disease and type 1 diabetes. And so, you know, broadly, we take kids from the general population, okay, as newborns, and then we genotype them. We look for the main celiac risk genes, right, DQ2 and DQ8. And out of those, you know, it turns out that 40% of the population actually has genes like DQ2 or DQ8 that puts them at risk for celiac disease. And then we break them up into kids who have 2 copies of DQ2, which is really the big risk, okay, versus kids who have just 1 copy of DQ2, versus kids who have a DQ2 and a DQ8, versus kids who have 2 copies of DQ8, versus kids who have just 1 copy of DQ8. So these are all kids that have a risk for developing celiac disease and diabetes. And then we check the celiac antibodies, the TPG antibodies on them annually, all right? And, you know, this is the microscope part. They're followed really carefully with a lot of questionnaires. You know, when do they get their first infection, their fevers, are they using probiotics, antibiotics? We take blood samples, urine samples, stool samples, all sorts of things to try to look for triggers of the celiac disease. And so not everyone with these genes are going to go on to develop celiac disease, but in general, okay, if you've got a gene that puts you at risk, about 3% of them will go on to get the celiac disease. Okay, and when you do have celiac disease, it turns out that about half of the folks with celiac disease will have symptoms. Okay, which means the other half don't really have a whole lot of symptoms. Okay, so part of what we've learned through DAISY, and DAISY recruited newborns between 1993 and 2004, is that you know, we can see that some kids developed celiac disease and some kids didn't. And so we can start to estimate the incidence of celiac disease within this population. It turns out that like within the first 5 years, there's a pretty rapid development of celiac disease that occurred. And that rate of new cases seemed to slow down after age 10. And from this, it turns out that celiac disease may affect up to 3% of children by age 15. And if you were only look at those who are biopsy proven, it's about 1.9%. So in Colorado, like I said, kids born between 1993 and 2004, the estimated cumulative incidence of celiac disease is about 2 to 3% by age 15. But then in TEDDY, TEDDY followed DAISY, and these are looking at kids born between 2004 and 2010. And this is unpublished still, but we're estimating that the cumulative incidence of celiac disease is at least 2% by age 10. So we're looking at a pretty high incidence, higher than sort of like what's always been quoted in the United States. And this is similar to reports that have found a high prevalence of celiac disease in Finland and Sweden. And it turns out that the majority of cases probably start off in childhood, right? Because it happens so early, but it doesn't mean that adults can't develop celiac disease. We know that adults certainly can develop it when they previously didn't have it before. So then who should we be screening? You know, I mean, I think there's a lot of arguments towards a couple factors here. One is that we should only be screening people who have symptoms. So if you look at individuals who have symptoms versus no symptoms, we know that half of all cases who have been diagnosed with celiac disease actually are subclinical or they may be asymptomatic. Right? What about the argument that we should only be screening people who have a high risk for celiac disease? And that's sort of like this blue box here. And this is according to the NASPGHAN guidelines, where people who have type 1 diabetes or autoimmune thyroid disease, autoimmune liver disease, juvenile chronic arthritis, those with Down syndrome, Turner syndrome, Williams syndrome, those who have selective IgA deficiency, and especially those who have a family history, like a first-degree relative with celiac disease, we should be screening just those individuals. Well, it turns out that most cases actually don't have one of these known risk factors. So most people aren't even at risk that we know of, right? And it turns out that the unifying factor here is just simply having HLA DQ2 or DQ8. That's a common feature. You know, if you have it, it's permissive for celiac disease. If you don't have it, then your chance of getting celiac disease is very, very low. So when we look at the risk of celiac disease by your HLA genotype at 10 years, remember, just by having the gene, your risk is overall about 3%. But you can start to stratify the risk of getting it based on how many copies of DQ2 or DQ8 you have. So if you have 2 copies of DQ2, then your risk through Daisy and Teddy is like, 15 to 18%. If you have 1 copy of DQ2, then your risk is 7 to 10% by 10 years. If you have 2 copies of DQ8, your risk is about 5%. And if you have just 1 copy of DQ8, that's sort of the lowest risk category. Your risk is about 1.5% by 10 years. And so, I think we should be really changing the way we define who's at risk for celiac disease. It shouldn't just be because you have a family history or because you have type 1 diabetes and things like that. It's really if you have the genes in general. So, why do some people get celiac disease and others don't, right? Yeah, you start off with that baseline HLA that's permissive, but we really don't know why some people do and other people don't. And through Teddy, we're looking at a lot of different kind of environmental factors that may be playing a role, okay? And whether it's the factors that lead to CDA, which is celiac disease autoimmunity, which is basically developing TTG or tissue transcutaneous antibodies, or actually developing celiac disease. And so it's very complex, right? I mean, these things are all interrelated, and some things may actually be low protective, some things may actually be a little bit more predisposing, but certainly there's not one unifying trait. There's nothing that's really hard hidden, okay? So there's no single factor involved in triggering autoimmunity, but in general, the big players we think are starting with baseline genes. You're gonna have diet and infections. Okay, so when we look at the genetics and other sort of immutable factors here, we know that HLA-DQ2 and DQ8 is really the strongest risk factor for celiac disease. And that basically makes celiac disease permissive, okay? Having a family history of celiac disease is a big player as well. Being female, it's about 2 to 1 over males as a risk factor. Turns out the country of birth or even the region where you were born plays a role in your risk for celiac disease. When we look at the role of diet, there have been a lot of studies that initially suggested that, like the timing of your introduction to gluten was going to play a role, but then 2 major studies, clinical trials, found that we couldn't really impact the development of celiac disease by changing the timing of gluten introduction. But it turns out that maybe the amount of gluten that you give a child, early on before 2 and 5 years of age could increase your risk, okay? And then infections, we do know that infections probably play a role, but how much, right? And it turns out that like early life infections do predispose you, especially GI infections, especially multiple GI infections, and especially enterovirus. It may be playing a role in also developing autoimmunity in a child who's at risk. So, in general, I mean, we know that celiac disease is a public health problem, okay? In Finland, it's as high as 2%. In Sweden, it's as high as 3% of teenagers that'll have it. And that's similar to rates that we just showed you that, that we're finding in detailed Colorado studies, okay? And, we know that 40% of the population has one of these risk genes for celiac disease, but not everyone with the gene is gonna get it, okay? Overall, about 3% of those with the gene will get it, but obviously it's higher if you've got certain gene combinations. Clinical detection can be difficult, right? And so over half of all cases are either subclinical or they could just be asymptomatic. Okay, and overall it's estimated that about 20% of all cases are actually diagnosed, which means most people with celiac disease don't even know it at this point. And there's certainly a lot of research that's being done right now to try to identify the environmental triggers for celiac disease.
Hello, everyone. My name is Benjamin Lebwall. I'm a gastroenterologist and director of clinical research at the Celiac Disease Center at Columbia University. And today I'm delighted to talk to you about the diagnosis and management of celiac disease. Now, when thinking about making the diagnosis, really the first question is, when should we be thinking about celiac disease? In what kind of person should we be thinking about doing a test? And so that's really changed over time because the popular image of celiac disease has changed over time. Shown here is an old textbook, and this was what we thought celiac disease looked like. We thought it was predominantly a condition of childhood, in which young children were having difficulty absorbing nutrients, and so as a result, they would have abdominal distension or swollen abdomens and diarrhea. They wouldn't be eating, they'd be losing weight and be wasting away. Thankfully, this is not the picture of celiac disease today. We still make the diagnosis in young children, and we still see people who have diarrhea as their predominant symptom, but there's so many other ways that people present with celiac disease. We call that non-classical celiac disease because it's not like the way the old textbooks describe them. So they would have for example, someone would feel fine, but they'd have low levels of iron or folate or folic acid in their blood on screening. Or maybe they had irregular bowel problems like constipation or told of irritable bowel syndrome. They might have issues with their dental enamel. They might have neurological symptoms. Maybe they feel fine, but going to the pediatrician, they're found to be falling off the growth curve in terms of their expected height. Or maybe they had elevated liver enzymes, or maybe they were having issues with fertility or osteoporosis, brittle bones, delayed puberty, fatigue. The list goes on and on. Shown here are just some of the more common forms of celiac disease. So when making a diagnosis, you really have to be keyed into the many, many different ways that this can behave. It very much is like a chameleon. It can have many different symptoms and signs, or sometimes none at all. In fact, there's something called silent celiac disease, where a person has celiac disease, but they feel perfectly fine. We pick it up, we make the diagnosis because we screened them, whether because they have a family relative who has celiac disease. So if someone's mother has celiac disease, they might get tested for it. Or maybe they have a condition, a medical condition that is associated with an increased rate or risk of celiac disease, such as type 1 diabetes. Now, we call that silent celiac disease, though sometimes people get diagnosed and then they tell us, well, in retrospect, it wasn't silent. I thought it was silent, but in retrospect, I was having to take a nap every afternoon. I was exhausted, or I had a lot of gastrointestinal problems. I was running to the toilet many times, and I didn't realize that that was not normal. And only after the diagnosis and treatment with a gluten-free diet did I realize that that was a symptom. Still, there are people who truly have no symptoms whatsoever. It's one of the more interesting things about this condition is it can cause such a wide array of symptoms and sometimes none at all. Shown here is the relative distribution in adults in the modern era. That is to say, these days when we have blood tests that can test for celiac disease. And the most notable finding of this pie chart is that the diarrhea only encompasses 43% of people who got diagnosed with celiac disease. There's this old notion that's actually shown to be a myth that everyone with celiac's got diarrhea. And in fact, the majority don't. And if you look at what are the other causes, things like abdominal pain and weight loss, but sometimes osteoporosis, bone disease, or anemia. Sometimes it's found incidentally. So someone has an upper endoscopy, a procedure looking at the esophagus because of reflux, and they're found to have an abnormal appearing small intestine, they get diagnosed. Or sometimes someone feels fine, but they get screened because of their family history. So it really is a wide variety of reasons someone might get tested and diagnosed. So how do you make the diagnosis? It typically starts with a blood test. And the blood test that has the highest accuracy is the tissue transglutaminase IgA. It's also known as the TTG. It has a sensitivity of 90%. That means that 9 out of 10 people with celiac disease will have an abnormal TTG IgA result. It has a specificity of 98%, which means that 98% of people without celiac disease will have a normal or negative result. But it's not perfect. These numbers are not 100%. And particularly, this is affected by certain people who have low levels or undetectable levels of a kind of antibody class called IgA. There are people who have IgA deficiency. And in them, it's harder to figure out if they have celiac disease. For that reason, there's another class of antibodies called IgG that have celiac-related values. And those could be tested, but they tend to be less accurate than the IgA test. So it is a trickier diagnosis and really needs to be done with the utmost of care. There's the deamidated gliadin peptide IgG and the tissue transglutaminase IgG. But really, those blood tests are not as accurate as that first one, the tissue transglutaminase IgA. If that is elevated, then a person will typically undergo an upper gastrointestinal endoscopy in which the small intestine is visualized. Shown on the left is a normal appearing small intestine, and each of these ridges is a fold that it really is there to maximize surface area so that nutrients can be absorbed. On the right is shown similar folds, but here you could see that it looks like almost chapped lips. These are called scalloped folds, like sea scallops. And it's one of the signs of damage we sometimes see in someone with celiac disease. But what's key is that actually both of these pictures are of people with celiac disease. How it looks to the eye when you're doing an endoscopy is not a great predictor of whether celiac is present. It's all about what it looks like under the microscope. And I'll show you some images there in a moment. A couple more endoscopy images. These are also of that small intestine right after the stomach. It's called the duodenum. Here, there's a relative loss of folds. We don't see as many ridges, and they're flatter. That's another sign of celiac, but that's not how we make the diagnosis. We make it by doing a biopsy of the intestine. Under the microscope, we see characteristic changes that clinch the diagnosis. On the left, these are what normal villi look like under the microscope. Villi are these finger-like projections that, again, maximize surface area of the small intestine. And in people with celiac disease, we call this so-called MARSH3. That's the characteristic that makes us most certain that someone has celiac. There is a flattening of those folds. We call it villus atrophy. Villus is a single fold like that, a finger-like projection. Atrophy means that it's basically shrinking or not of the normal size. So it becomes flat, and it's flat because it is being attacked by these white blood cells called lymphocytes that are triggered by gluten. They see gluten as a threat, and they're causing inflammation there and damage. And so as a result, the villi become flat. Shown on the left is a normal biopsy result. This is someone who does not have celiac disease, and you can see there's a normal villus. There's this finger-like projection. And shown on the right, you can't see those projections because they're all flat. So this is someone with celiac disease who's still eating gluten because the diagnosis has just been made. Now, typically, we start with a clinical suspicion. Maybe someone has one of those symptoms, and those antibodies, the blood tests, are checked. And then, as a result of a positive antibody, a biopsy is performed. And if it shows villus atrophy, that abnormality, the diagnosis is confirmed and the gluten-free diet is begun. But as the schematic shows, there are multiple opportunities where people might fall through the cracks, whether because a biopsy wasn't done, or a blood test was misinterpreted, or one of many other things. Someone might go to the doctor and the doctor might not think to test for celiac disease. So those are called false negatives. We also have the problem where someone is told celiac disease when in fact they don't have it because perhaps a blood test or a biopsy is misinterpreted. What about skipping the biopsy? Well, there are relatively new European guidelines that apply to children, not adults, but children, that say that if you have a very highly elevated antibody and the child has symptoms, you can make that diagnosis based on that. It would apply to about half of all cases of celiac disease among children in Europe. We're concerned, though, that if we skip the biopsy, we might miss other diagnoses that would be picked up during the endoscopy, looking at the stomach and esophagus. And also, the positive predictive value is not 100%. In other words, if you have a very highly elevated antibody test, it's not 100% sure that you got celiac disease. And because the treatment, the gluten-free diet, is a lifelong or long-term treatment at least, we want to be close to 100%. So that's why we've been hesitant to adopt that guideline to children in the United States or to adults. There is genetic testing that can be done for celiac disease. It's not a way to make up the diagnosis, but it's a way to potentially rule it out in certain cases. You see, the gene, it's called DQ2 or DQ8, is present in 100% of people with celiac disease. It's a common gene. 40% of people in the general population have this gene too. So when is it useful? If it is not present. If we do the test and it turns out that that gene is absent, then we're sure that that person doesn't have celiac disease. So we do that when we're testing relatives of someone with celiac disease as a way to see if we ever need to think about celiac in a person. We do it in people whose biopsy or blood test is questionable, borderline elevated, not so sure. Or we do it in people who already started the gluten-free diet before they got tested for celiac disease. Because unlike the blood tests and unlike the intestinal biopsy, your genes don't change over time. And so those can be tested at any time. And if that gene is negative, then you don't have celiac disease. Now, there are mimickers. There are people who have those changes on their biopsy of the intestine, but they don't have celiac disease. Here's just as an example, a long list of some of the other things that can cause villus atrophy. So just because someone has a biopsy that looks like celiac does not necessarily mean that they definitely have it. That's why we like to rely on both the blood test and the biopsy. It is possible that someone will have a normal blood test and a biopsy that shows celiac disease, and indeed they have celiac disease, but we always look very closely at that situation and make sure that gluten is the culprit and that they get better with a gluten-free diet, simply because there are these other causes. After the diagnosis is made, an acronym shown here shows what should be done. The first thing is the most important: consultation with a dietitian who's expert in celiac disease, but also education about the condition, lifelong adherence to the gluten-free diet, though maybe if we develop treatments aside from the diet, maybe it won't be lifelong, but we say long-term at least. Identification and treatment of nutritional deficiencies is important. Access to an advocacy group and continuous long-term follow-up are all part of management of celiac disease. But sometimes we're asked, can't people just Google it? Just Google gluten-free diet? The problem with that is there's a lot of conflicting information out there. You need to learn not just how to avoid gluten and know what not to eat, you need to know what to eat, how to have a healthy gluten-free diet, one that has enough fiber, one that has the adequate, not too little and not too much amount of calories, so one that allows for a healthy, stable body weight, and one also needs to know about the potential hidden sources of gluten. After the diagnosis is made and a dietitian expert in celiac disease meets with the person diagnosed, there's other monitoring that's done, including monitoring bones. So in adults, we do a bone density to screen for osteoporosis or brittle bones. We do blood tests periodically to monitor nutrients and for other autoimmune conditions. And some advocate for checking the biopsy a second time, typically a couple of years after starting a gluten-free diet, to see if things have healed. This is much more popular in adults than on the pediatric side, but it seems to be one way that we can monitor to make sure that people are avoiding gluten adequately. There are a number of reasons people might not feel better after starting a gluten-free diet. One of the most common, actually, is that it was never celiac disease to begin with, and so we always very carefully review the diagnosis. And then gluten exposure. That's extremely common because gluten is everywhere, and you'll be hearing more about that shortly. There's something called refractory celiac disease, which is rare. That's where, despite strict avoidance of gluten, the intestine remains damaged and the person has consistent symptoms of, or persistent symptoms of, not absorbing nutrients. Fortunately, that occurs in probably less than 1% of people with celiac disease. So if you suspect celiac disease, a blood test should be done while you're eating gluten. Intestinal biopsy remains the main way to confirm the diagnosis. And once someone starts a gluten-free diet, the clock is ticking because the blood test and the biopsy can become normal. Right now, the gluten-free diet is the only effective treatment of celiac disease. And so expert guidance with a dietitian is key, and follow-up, as outlined previously, is appropriate. Thank you for your attention.
My name is Dr. Jocelyn Sylvester, and I'm a pediatric gastroenterologist and researcher at Boston Children's Hospital in Boston. And today I want to pick up where Dr. Lebwohl left off, where Dr. Liu left off, and talk about some of the gaps we have and some of the things we need to know in celiac disease. So to start off with, I think one of the questions that we face a lot is this notion that celiac disease is a solved problem. And I think while we have tools for celiac disease, we have a treatment that's not a cure, and we definitely could have more in our toolbox in order to be able to manage the condition. So I think really the paradigm has been, you have somebody who's sick with celiac disease, they have villus atrophy, you take gluten away, they feel better and their villi grow back. We're learning that it's actually more complicated than this. So I want to take a minute and think about another autoimmune disease, type 1 diabetes, and what the tools are in type 1 diabetes and what we might have in celiac disease that's like that. So one thing about diabetes is that there's glucometers, so any patient can prick their finger and get a readout of how their blood sugar control is at that exact point in time. If there is a low reading or a high reading, there are different treatments that the patient can use in order to get that back in the target range. And there's also continuous monitors so that the patient doesn't have to be as involved in this progress, and they will continually read blood glucose and signal the patient when there's a problem so that they can act. There's also pumps to deliver medication so that patients can semi-automate the process. In terms of monitoring in the clinic, there's hemoglobin A1C, which is a more long-term measure of control. And then there's also emerging preventative therapies that might delay the onset of type 1 diabetes. So a variety of tools to manage various aspects of the diagnosis. I think in celiac disease, we would like to have more tools. We have good markers for diagnosis of celiac disease on a gluten-free diet. We don't really have great tools for monitoring patients who are on treatment. And I'd argue that the gluten-free diet treatment is inadequate and not a cure. And as of yet, we don't have preventative therapy. So while we have some tools in our toolbox, there's some others on the shelf we'd like to have. So talking briefly about diagnosis, I think we've heard a little bit about this today, and I'd just like to point out that we really don't have great diagnostic tests for patients who are not on a gluten-free diet. And once patients are on a gluten-free diet, putting them back on gluten in order to confirm they have celiac disease and get a diagnosis is much more complicated and very nuanced. And so really we need a better tool for patients who are already on a gluten-free diet. As well, we have TTG, which is a screening test, but we really don't understand how best to use this and which patients should be tested. We frequently see patients who feel they should have been tested earlier, and we know that there's many patients who aren't diagnosed. And so we need to figure out how to recognize the patients who need to be treated. I want to focus mostly on treatment because I think most people are most concerned about the disease for the rest of their lives after their diagnosis, when right now there's one treatment, which is a gluten-free diet. And so the paradigm, as I showed before, is that somebody's sick, they have short villi, they take gluten away, or they try to take gluten away, and then what happens next? Ideally, they feel better and their villi get better, but what's happening? So this is actually from Dr. Dickey's thesis, where he reported the effect of a gluten-free diet. And I think this really encapsulates really the problems with this treatment. So this is a growth chart of height from a single patient who you can see had many admissions to hospital. And when they were admitted to hospital, they got initially diagnosed, put on a gluten-free diet, and they grew. And then they went back home and they didn't grow so well, admitted, grew, flattened out. And what we're seeing here is that a gluten-free diet is easy to do in hospital, but much harder, even if you're in the hospital, if you're going to school. And I think this is one of the aspects of celiac disease treatment that can't be understated. And thinking about children, here's some data from Canada looking at what aspects of socializing and what feelings are evoked among children who are following a gluten-free diet. And so this treatment is not one that is benign, and it's also not one that children can necessarily hide, as often they have to ask questions or their food looks different. What about adults? This is a study where patients with different conditions were contacted and asked to fill out a generic questionnaire about how burdensome their treatment is. And you can see that, well, celiac disease is not number one, it's number two. And the disease that was felt to be more burdensome was kidney disease, and these were patients who are on dialysis. And so definitely, while celiac disease and a gluten-free diet is not dialysis, the burden can be similar. Now, is it worth it? Yes, it's a lot of work, but often things are difficult. And so is there an alternative? Is a treatment worth the cost? And so I think it's important to point out that in a so-called gluten-free diet, there can be gluten, and even products that are labeled gluten-free can legally contain up to 20 parts per million gluten. And so one of the questions is, how much gluten are our patients actually getting? So this is a study that we recently conducted where we took 3 people who did not have celiac disease, who were following an unrestricted diet, and 18 people with celiac disease. And we collected food, stool, and urine samples over a 10-day period. On the top panel, you can see the results from the control patients who are eating gluten, and you can see that there are many samples over the 10-day period that contain gluten. This is the same data. The top is the control patients again, and then the bottom is the 12 of 18 patients who had a gluten exposure. And so what you can see is all of these patients who are trying to follow a gluten-free diet, who are not eating gluten on purpose, gluten can get in from time to time in varying amounts. And one of the things we don't know is how important this is. However, it's probably representative. When we ask patients about their gluten-free diet, a large proportion will say that they have accidental gluten exposures less than once a month, suggesting that these gluten exposures are probably real. And so the question is, yes, there may be some gluten. Is it gluten-free enough? And what are our markers there? How is the patient feeling? Do their symptoms go away? And what happens to their villi? So this is 2 studies looking at so-called non-responsive celiac disease, which is patients who still have symptoms on a gluten-free diet. And what's important here is that, yes, you can have celiac disease and another disease, but really one of the leading causes of symptoms is ongoing gluten exposure, which I think really speaks to how difficult it is to avoid gluten and how imperfect a gluten-free diet is as a treatment. This is a graph that's looking not at symptoms, but at, if you were to go and do a repeat biopsy, how many people are going to have villi that look normal and healthy? Because the thought is that if you take gluten away, the villi will grow back. What you can see, the bottom axis is age, and so and the top axis is the number of people who still have damage. And so as people are older, they tend to have more damage. And there's also, it takes more time to get better. So while 1/3 of people may have a healthy intestine after 2 years, 2/3 would have a healthy intestine after 5 years. And so the length of follow-up is also important, because a gluten-free diet doesn't necessarily help overnight. So what's the state of celiac disease treatment? We have a gluten-free diet, which is the current mainstay of therapy. It's socially difficult, emotionally difficult. It's not gluten-free. It doesn't resolve symptoms in everybody. It doesn't lead to mucosal recovery in everybody, and it may actually decrease health-related quality of life. So I know that we're having an excellent session coming up on treatments for celiac disease, but I want to take a moment to just ask, what would a treatment for celiac disease look like? And I think there's really sort of 2 broad classes. One would be something sort of like a lactase enzyme that would help patients who are trying to follow a gluten-free diet for this gluten that gets in. The other would be something that would replace a gluten-free diet, some sort of immunization or injection that retrains the immune system so it doesn't attack gluten. So finally, I want to talk a little bit about what we do monitoring patients with celiac disease, because in type 1 diabetes, you can measure blood sugars, you can measure hemoglobin A1C. In celiac disease, we have a little bit of a circular problem, because We ask if people are taking their treatment. We can't figure out if they've gotten their insulin prescription refilled, so we have to quiz them about what they've been eating. And depending on who's preparing the food, they might not actually know. We do have some tests to look for gluten in urine and stool, but these are expensive and you can't do them continuously, so you're really only getting a spot measurement. We also can look at immune activation, but these tend to go down when people are on a gluten-free diet, even if there's still gluten and even if their intestine still has damage. We can do an intestinal biopsy, but people aren't necessarily signing up for that all the time. So I think in summary, we have measures of behavior and we have measures of biology. It's not necessarily clear where symptoms follow in. And ultimately, we don't have great tools to really get a good handle on how patients are doing, which means that patients also don't have great tools to feedback on how they're doing and if they need to adjust their gluten-free diet. So in summary, I'd argue that celiac disease is not a solved problem, but a problem to be solved, not only in terms of finding a better treatment, but also finding better tools to diagnose and monitor patients who have celiac disease.
Okay, so I'm Ben Lebwall, one of the three speakers whose video you just watched. I'm joined today with Dr. Ed Liu, and we're here to field some of the questions that have come in through the chat. So why don't we get right into it? Before we get started, though, I should thank you all for attending. I'm seeing how many participants we have, and this is just extraordinary. We have a community that's really dispersed, and so to see so many people engaged in celiac disease all at the same time is just to me personally very heartening. So thank you to the CDF and to this summit's sponsors. So why don't we start, Ed? If I could ask, there was a question about you have someone who's got a family history and they're getting screened and they test negative. Could they then subsequently test positive? And how often does something like that happen where someone goes from not having celiac disease to having it? And how do you deal with that? How do you monitor someone?
Yeah, that's an interesting question. So I think the first thing to keep in mind is that no one's born with celiac disease, right? I mean, you're born with the genes that put you at risk. And not everyone who has the genes will also get celiac disease. So someone could be tested at one point and not have it, and then later on they can develop it. So yes, that can certainly happen. And we see this a lot, for example, when we're doing screening in groups who are at risk, for example, individuals with type 1 diabetes or people with family history, where we may test them once and it's negative, and then we test them every year or two, and at some point it can become positive. And I think there's a lot of potential triggers for this, but we just don't understand what they are yet.
Is there an age beyond which if someone tests negative, it's very unlikely they're ever going to develop celiac disease?
No, I think it's important to note that you can develop celiac disease at pretty much any age. Maybe the youngest that we've seen in our studies was 9 months, but that's awfully young. But sort of what we've seen in other studies we've seen is that the rate of development in celiac disease happens much more quickly, we think, in kids. And typically by age 10, age 12, that's the most common time to develop celiac disease, but we also know that adults can develop it. They could have been tested at one point and be negative and then develop it later on. So yes, this can also occur in adulthood.
Thanks, Ed. So I'll take a question that was asked about why don't we just have celiac as a marker that we put on, just like we check for people's cholesterol, check someone's blood sugar. Why isn't it just like on a standard panel of standard blood tests someone gets? And someone could go to the doctor every year and still never get tested or diagnosed with celiac disease and elude diagnosis. I think that the simple answer to that is it still remains unclear the benefit of diagnosing someone who feels perfectly well. And so we have the problem of people who are ill, who are going to the doctor and not being properly tested. And that's on us as advocates and educators. But to really go out there and take someone who really was just coming in for a checkup and feels fine, diagnose celiac disease and put them on a gluten-free diet, we honestly don't know how much or if we're helping that person. It's possible that in retrospect, they're feeling a lot better. It's also possible that they were going to be fine having some degree of untreated celiac disease. It doesn't sound right and sound good to have ongoing intestinal inflammation that goes untreated for many decades. But the truth is, we like to practice medicine based on proof and not based on our supposition. And it is possible that given the difficulty of a gluten-free diet for people, especially people who are feeling well, we'd like proof. And there are ways to test this with large randomized trials of screening. That would be very expensive and take years, but we're still working to push, particularly for governmental funding for such a study so that we can decide once and for all, how should we screen people and how often, even if they're feeling well, does that benefit people? Ed, do you have thoughts on that question?
Yeah, no, I agree with that. I'll let you finish with that.
Why don't I ask about a question that was asked to you about celiac disease among people of color? So they seem to be underdiagnosed. And how common is celiac disease in certain racial and ethnic groups, aside from the white European group that's been the primary area of study? And any recommendations on that?
Yeah, I think that's a really important question, and we have to recognize that celiac disease can affect pretty much anybody in pretty much any country. You just have to have the genes. And yes, it's true that the great myth is that this only affects, for example, the Northern European countries, but it really can affect anybody of any race. It's true that Caucasians tend to have more of the major celiac gene, the DQ2. In our studies, though, in Colorado, African Americans also have the same percentage of DQ2 in their group, and Asians have a little bit less. The Hispanic population has more DQ8. But basically, we do see it in pretty much anybody if you have the gene. And so I agree, a lot more needs to be done to study the minority groups.
So there was a question about the genetic tests for celiac disease, and can you really 100% rule out celiac disease if someone has a negative gene test result? So in my slide presentation, I mentioned 100%. Of course, in medicine, 100% is a really tough, high bar. We like to say, if someone doesn't test positive for this gene, we really need to look very closely at this diagnosis. The most common reason a celiac would test negative is because actually the way the gene test report is listed, they actually have half of the copy of one of the genes. And if you just read the top of the report, it says test negative. There's something called HLA-DQ 2.2, for instance. That we consider a positive genetic test, but 23andMe, for example, will not mention that as a positive genetic marker. So that's the most common reason, but it really does raise the question of the diagnosis, and it mandates that we take a careful look at the blood test, the biopsy, and then is it possible that they are somehow the exception to the rule? There is increasing interest in so-called DQ7, and so there might be a small population of people who truly are entirely negative for those two genes that we routinely test for, but have celiac disease, but they are the exception. I would say that if we want to be more accurate, it would certainly be 99.99, maybe a couple more nines, but maybe not quite 100% for that reason. Ed, I'd love to ask you something else, but I'm looking in this long list of questions. I'm wondering if you'd picked out any other favorite questions you'd like to ask or answer.
Well, there was one about the EAT study. There was a question about a study that just found that maybe if you introduce gluten early, it may actually be somewhat protective. And I think it's true. I mean, there's a lot of hypotheses in terms of like how we should be feeding our kids to try to reduce the risk of celiac disease. And I think we have to be really careful about over-interpreting any of these studies. We always need more proof before we make any kind of major recommendations. But the two big studies conducted in Europe to try to prevent celiac disease in kids who had a risk were really designed to try to delay the introduction of gluten. And both of those studies weren't able to really affect disease onset. And then the one that was sort of asked about, which was trying to feed kids earlier, does show that there may be some protection as well. But bottom line is we don't really know what all the rules are of the immune system. are yet. So we can't give any kind of recommendations in terms of how to feed our kids other than what the American Academy of Pediatrics recommends. Just feed them normally. And once we do have some definitive information, then hopefully this will affect policy, but you just have to hang tight.
There was a question about, why aren't we diagnosing celiac disease more often? Why are people remaining undiagnosed? What I'd say is there's certainly an improvement compared to a decade or two ago. Diagnosis rates are increasing. That is just a hard fact. It does appear that there are multiple patients who are left behind, though, who are remaining, seeking out healthcare and remaining undiagnosed. And I think it's complicated. I think it has to do with the way our healthcare system deals with treating certain conditions. The fact that the treatment is a diet and not a pharmaceutical, frankly, impacts physician education, unfortunately. Again, this is on us, and educating physicians is key. There might be, to some degree, a generational thing because it used to be thought that celiac disease was rare, and the many different aspects of celiac disease were not necessarily appreciated to someone who was trained generations ago. And some people are better at keeping up in progress and medical progress than others. But I think that one of the keys for today is the importance of self-advocacy. And it's so common for patients who, when they're diagnosed, to say that actually I had to speak up in order to get the proper test and care that I need. So we appreciate that. Ed, any comments? I think that after that, we're going to be out of time.
Yeah, no, I totally agree. And I really appreciate everyone for attending this, and I appreciate the opportunity to join you guys.
All right, looking forward to the remaining sessions, a day full of education and community. Thanks, everybody.
I Cure Celiac gives you the power to cure celiac disease, a serious autoimmune disorder that causes debilitating symptoms. 3 million Americans suffer from the disease. That's more than all of the people with multiple sclerosis, Crohn's disease, colitis, and Parkinson's disease combined. Yet 5 out of 6 people are never diagnosed, and those who are have spent years searching for an answer, visiting multiple doctors. The disease is hereditary, so people with a first-degree relative with celiac disease have a 1 in 10 chance of developing celiac disease themselves. It affects people all over the world, with the number of cases growing. This is alarming because if celiac disease is not treated, it can cause serious health problems like type 1 diabetes, thyroid disease, heart disease, and even different types of cancers. Yet the only treatment is following a strict gluten-free diet. But even accidental exposure to gluten can cause serious damage. There are no alternative treatments, but now you can change that. You have the power to help researchers improve treatments and find a cure. You know celiac disease better than anyone else. So share your voice, your experience, your knowledge. Enroll in the iCure Celiac Network and enter your personal health information. It's easy, and iCure Celiac uses advanced technology so you can be sure your information is safe and secure. And the best part? You control how much data you want to share and who you share it with. You see, when lots of people join together and input their data, researchers can launch more studies faster and analyze large groups of patients. This means that you and every patient with celiac disease have the power to speed up the search for treatments and a cure. Join iCure Celiac, and let's start solving celiac disease together.
Hello, everyone. I'm Jennifer Voigtsener. I'm the scientific co-founder and chief scientific officer of Immunogenics, and I'm also a diagnosed celiac patient. And I wanted to say a big thanks to CDF for inviting me to participate in this great event. I really hope you all enjoy this session and come away with some valuable information and motivation. As a CD patient myself, and even as a drug developer, I'm well aware And I know exactly how it feels to wonder, is there ever going to be a drug? Is there ever going to be a therapy approved? And what, and if yes, why is it taking so long? Well, that's what this session is all about. We'd like to give you all an update on celiac disease drug development. And at the end of the session, you'll be able to ask the speakers yourself a question. And so while you're listening, please do plan to ask a question. So as you'll see in the first presentation, there are many aspects of the celiac disease immune mechanism that warrant study. And so thankfully nowadays there are many drug developers in the space who are in various stages of developing therapies, drugs, tools, and so on to manage the disease. Immunogenics is thankfully one in the space, and we're developing lataglutenase, which is an orally administered therapy that breaks down gluten in the stomach. We're also developing a series of diagnostic tools for the management of CD post-diagnosis. Another thing we're developing is an electronic patient-reported outcome tool called the Celiac Disease Symptom Diary. And this records symptoms to assess the well-being of patients while they're on their diet. We've just finished one phase 2B clinical study. We're recruiting for another now, and we'll be recruiting for a third in about 1 month's time. Unfortunately for everybody, COVID has put a wrench in everybody's clinical trial plans, but we're all hopefully managing to circumvent that and move forward. So before we get started, I talked to some colleagues, and I wanted to share some of their insightful comments about the drug drug development process. One colleague describes drug development as a research ecosystem. And if you think about that, you can imagine it's comprised of many participants and each with a vital role. And if they don't all collaborate with each other, the system will fail. And another academic colleague said, it's not just big pharma and the FDA. Academic collaboration with a drug developing sponsor, whether they be big or small, is a key component of bringing new treatments to people with celiac disease. He shared, at our center, we have the patients, we have an active research program, but we do not develop the medicine. We need innovative developers to invest in CD and to work with us to execute the proper trials. But how do you do these types of academic collaborations? How does it all fit together? Well, here in the US, the backbone of R&D that enables advances in diseases like CD is government funding, specifically NIH. And we're extremely lucky that this funding exists. Basically, 2 research programs that NIH supports via grants are basic science programs, which fund directly to the academic researchers, and translational research programs that work as a collaboration with a small business like Immunogenics and an academic center. Both of these programs are rigorously peer-reviewed and follow time-honored processes for selecting the best ideas. One of my research colleagues said, these NIH programs are the envy of other countries across the world. We should do more to support it. Patient support groups like CDF can and should do a lot to educate patients as well as legislators at all levels about the value of supporting the NIH funding initiative. But there's one critical detail that I need to share, and that is currently government funding for CD research is the lowest of all the GI diseases. That's a key takeaway that we should all remember. This is something we have to change and something definitely worth advocating for. But there's also other sources outside of government funding. And ultimately, we need all of it, especially once the clinical program reaches the later stages. These large clinical trials are incredibly expensive to conduct. So there's private investment, angel investment, funding from foundations such as CDF, Gates, AGA, etc. Then there's investment from venture capital, industry, and of course the government funding, which I've just highlighted. I was asked to briefly share our experience with funding because we are somewhat unique with respect to government funding. So as Immunogenics started, we started with personal investment, then secured support from private and angel investment. But the really big deal for us was securing government funding via NIH. Given that research is the lowest funded GI disease for celiac disease, we're extremely proud to have been granted 3 large NIH small business innovation grants. As I said, we've just completed an NCCIH funded study at the Mayo Clinic. Our NIAID funded Celiac Shield study is enrolling now, uses 2 academic centers of excellence, Mayo Clinic and Columbia CD Center, as well as 2 private practice sites. Our NIDDK funded study, which doesn't have a name as of yet, will enroll soon, within a month or 2, and we will be working with Stanford University's Type 1 Diabetes Center to study both CD and T1D patients. This NIH funding has offered us amazing opportunities as a small sponsor to utilize the expertise of these key opinion leaders and clinicians at the centers of excellence, and we would never have been able to do this on our own funding. Lastly, before we move forward with the session, I wanted to highlight you, the patients, your families. You may not realize the extremely important role you all play in the CD research ecosystem. Each one of you is gold. Why? For 2 reasons. First, you're essential for our clinical trial success. No program can move forward without successful trial data at each step. Without that, there endeth the chance for more funding to continue the program. I think I can speak for all drug developers when I say how grateful we are for each one of you. And we do appreciate the awkward and uncomfortable things that we ask you to endure in our clinical studies. So thank you. Second, you're essential as advocates for government funding. Please consider being part of CDF's program. And you can learn how to approach your legislators to advocate for more research funding for us. So with that, I'll thank you for your attention. I know you'll enjoy our next 3 speakers, and I really encourage you to please ask a question in the Q&A session, because this is your event and this is your chance to learn, so don't be shy. Enjoy.
Good afternoon. My name is Francisco Leon. I am the Chief Scientific Officer of Prevention Bio, and it's a great honor for me to be speaking with you for a few minutes about the history of the development of medications in celiac disease. I want to thank Marilyn and the Celiac Disease Foundation for this kind invitation to the Patient Education and Advocacy Summit. By way of disclosures, I've been working in celiac disease for a very long time, more than 25 years. I did my PhD in celiac disease in the 90s, and I have been CEO, CSO, Chief Medical Officer of several companies, such as Alba Therapeutics, Celimmune. I have started 3 companies, including Gluten-free, and also work with Biometal in the diagnostics space. So I do have a witness position to the development of celiac, which I would like to share with you. The first thing that we need to ask ourselves when we think about whether we should develop a drug for a disease is whether there is really an unmet need or not. In the case of celiac disease, clearly the gluten-free diet is not a solution. And that was the big realization that drove the entire field. We know that even though gluten-free diet is efficacious at quickly reducing symptoms and intestinal damage, it's very hard to completely heal as little as 50 milligrams of gluten a day, and compare that to 20,000 milligrams in a normal diet. 50 milligrams will drive intestinal inflammation and symptoms. So clearly there is a need to address what we call now gluten-free diet, non-responsive celiac disease due to consumption of gluten on the diet. The gluten-free diet is very burdensome, and in this study from Dan Leffler and collaborators, we learned that celiac disease has the second highest burden of disease treatment of a long list of diseases, only second to end-stage renal disease and dialysis. So very high burden of the gluten-free diet in celiac, and still not effective. That is why patients have been asking for adjuncts to the gluten-free diet, medicines that will allow cross-contamination to be tolerated or intercepted so that it doesn't cause damage. Almost 90% of patients want an adjunct to a gluten-free diet. And a good number of patients are also interested in avoiding the diet altogether. So in addition to checking the first box, which is, yes, we have a need for a new medication, the next thing we need to realize is for a single drug to be approved by the FDA, we need to have dozens of drugs in development in order for one of them to make it through the end line. We need investors, private investors, to contribute as much as $1 billion on average for each drug that will make it through market because of the high degree of failure. If we don't have at least 5 drugs in clinical development, we are not going to get one approved. The advantage that we have in celiac disease is that we understand the pathophysiology, that is the mechanism of the disease, better than most diseases. And that is the one thing that we have going for us. We know that gluten crosses the gut barrier and it gets modified by an enzyme called transglutaminase. It's presented by antigen-presenting cells to lymphocytes. And there are a number of inflammatory cytokines. One of them is interleukin-15, and others that activate cells called intraepithelial lymphocytes, the IELs, which kill the cells in the gut mucosa, in the gut wall. We also know that the T lymphocytes activate B lymphocytes to make antibodies, which are the markers of the disease. So armed with this knowledge, we started in this field with a few pioneers. The first company in the development of drugs for celiac was Alvine, started by Professor Chaitan Khoshla in California with a glutenase, ALV-003, which is currently being developed by Immunogenics. Alba Therapeutics, and I worked at Alba, was the second company, Professor Fasano, with larazotyl acetate, currently in development by 9 meters. Chemocentrics with Traficet, which did not work. Immucin T, Bob Anderson, with an XVAX2, a vaccine, which also did not show efficacy in phase 2. And the University James Cook in Australia with Necator americanus, infecting patients with a worm to fool the immune system against reacting against gluten. Of all of these companies, it's interesting that most of them no longer exist. Alvine doesn't exist, Alba doesn't exist, Immucin T doesn't exist, Chemocentric no longer works in celiac, and the James Cook University trials have not shown efficacy except symptomatic efficacy, but no gut efficacy. So this just tells you the high degree of failure and attrition in drug development. But all of these pioneers did create a fertile ground for the current explosion of research that we see. Today, we have over 25 programs, half of them in clinical development here in green, and another half in blue in preclinical stage of development. So now we have critical mass, which is what we need to ensure that in the next 3 to 5 years, we are going to have drugs making it in front of the FDA for approval. I'm not going to go over every company, we don't have time today, but just in high level, there are companies working on modifying gluten. That would be very interesting. However, it will imply you can only eat that modified gluten. So it's still leaving some unanswered questions. 9 meters, again, developing larazotide. It's in phase 3 for symptomatic improvement in celiac disease. The knowledge about transglutaminase by Professor Schuppen in Germany led to Sedira developing a transglutaminase inhibitor, and Professor Koshla has his own program with Citari. We also have all the glutanases, again, immunogenics with latiglutenase, now Takeda entering in the space with what was previously PVP, Cumamax, now called TAC-062. We also have all the attempts to block the key cytokine, interleukin-15, the key driver of intraepithelial lymphocytes. The company I work for, Provention, has a program in phase 2B partnered with Amgen called PRV-015 or AMG 714. We're currently recruiting for the proactive celiac study. Joe Murray has been doing work in refractory celiac disease as well with an anti-interleukin-15 receptor. And there are a number of other preclinical programs for IL-15, Calypso, Bionis, and others. The most interesting final aspect of this development is the attempt to manipulate immune tolerance. And there are many, many companies in the immune tolerance space. Probably the most advanced is Takeda's TAC-101, and this was formerly Course company MPGLI, now in phase 1B/2A. There are others like Anokion that have also made it through the clinics and are now developing their own version of immune tolerance agents, and multiple preclinical companies. The message I want to leave you with is that we are in a good moment for celiac disease research. We have a lot of activity, but there is one thing that is essential, and that is for patients to participate in clinical trials. All of these trials require volunteers. If we don't have volunteers, we will not be able to complete the trials on time. We will not be able to get support financing for these studies. So while I leave you with a very, very big thank you to all of the patients who make research possible and to the Celiac Disease Foundation for leading this field, I also leave you with a plea, please join the studies. We'll try to make it as easy as possible for you, and especially in time of COVID. We'll try to make it very safe and together advance the field. Thank you very much.
Hi, my name's Dan Leffler. I'm a gastroenterologist, an associate professor in gastroenterology at Harvard Medical School in Bethesda, Deaconess in Boston, and a senior medical director at Takeda Pharmaceuticals, where I am the clinical development lead for the celiac disease program. So I've been asked to talk to you a little bit today about endpoints in celiac disease trials. And I know that may sound like a little bit of a dry topic, but it's actually really, really critical. And so I hope you'll bear with me, and I'll tell you a little bit about what all this means. First off, though, I do want to say that the most important thing that I'm going to say during any of these talks, and I say it all the time, is that we need you to participate in trials. We cannot make progress in celiac disease without the help of the celiac community, without continued efforts of people volunteering their time to participate in our clinical trials. So I thought that a good way to start this talk was really to talk about what you should ask about being in a trial if you're considering that. And again, I hope you will consider being in a trial. And the first thing you're going to want to ask is, what is the intervention, right? What are they doing? Is it a diet tool? Is it a new technology? Is it a new medication? All of these are clinical trials that we participate in. We think a lot when we say clinical trials, we're talking just about new drug therapies, which again, is an important part of what we do, but there's lots of types of clinical trials, lots of types of clinical research, all of which will have an intervention. So that's the first question you should ask when you're participating in trials. What's this intervention? Second question is, who is it for? Is it right for you? Are you the type of person they're looking for? Third is the risks What risks could this have? Is there a risk to privacy? Is there a risk of a new medication? All of those things you're going to want to know if you're thinking about participating in a trial. The next one is the outcomes. And this is what ties in probably most closely with the topic of my talk, which is endpoints. But it's what are the outcomes? What are they actually looking for in a trial? Is it primarily safety? Is it some form of efficacy? What does that efficacy look like? Is it a change in behavior? Is it a change in how you feel? Is it a change in a blood test? All of those are important because they should be relevant to you. If you're going to participate in a trial, no matter what it is, it's really important that it means something to you. And the best way you'll know that it means something to you is what those endpoints are and what those outcomes are. Do they feel like they are, again, something that you can relate to? And finally, with any trial, there's going to be something that you're asked to do, whether it's fill out a survey or take a medication for a year. Any of these are on the list. It could be endoscopies, it could be a lot of different options. So what tasks and work, and does that actually fit into your life and routine right now? So those are the things you really want to think about when you're thinking about participating in a trial. And all of that is really dependent on the endpoints the study is going to look at. And so that's why really the endpoints are so critical, not just for how you design a trial, but for whether the trial is actually right for you, because it's the endpoints that define each of those things. They define what's done and when it's done, who it's done with, what the risks are and how those are evaluated, what the study outcomes are, and again, how they're measured and the types of tasks and work you do. So that's a long way of saying that the idea of endpoints is very, very broad, but it is the first thing we think about as scientists when we're designing a trial. We want to know what it is we're trying to do, what it is we're trying to show or prove or change in some way or another, because that really defines everything else we do and how we design the trial. It defines what kind of tests we do, how long the trial is, what kind of monitoring we do in the trial. So each trial will have some combination in general of safety endpoints and efficacy endpoints. So is what they're doing, what we're studying safe? Sometimes if it's just a survey study or something like that, there'll be very little in the way of a safety study. But even in interventions of new dietary technologies, there should be a safety arm. I think one of the better examples of this in recent celiac disease history is the studies that were looking at the portable gluten sensors for food, whereas they looked at the efficacy, e.g., could it actually help prevent gluten exposures that were symptomatic. But they also looked at something that was a safety endpoint, is did this cause hypervigilance? Did this make people so concerned and anxious that the avoidance of gluten was offset by the psychological burden of using the tool? So that's a good example of something that you wouldn't necessarily think of a safety endpoint, but there still was, because it was a well-designed trial that, again, will almost always have safety and efficacy endpoints. And so that's, one of the points of telling that is to say that just because a study is studying safety endpoints doesn't mean it has a safety issue that you need to be particularly concerned about. This is just part of doing a good job being a diligent scientist, is that you're looking at all ends of the spectrum, because there can be unintended consequences of almost any type of intervention. So next, let's talk about the efficacy endpoints, because this is really where I think a lot of attention is rightly focused. And it's an area that's really unsettled in celiac disease. And that's, the bad of that is that we have a lot of work to do, and we don't have a set way of doing clinical trials. And so there's a lot of evolution right now. But the exciting part of that is there's a lot of evolution right now in celiac disease and what endpoints we use in clinical trials. So the big categories, as I think about them, are biomarkers and patient-reported outcomes. So biomarkers can be anything from biopsies of your small intestine to specific blood tests like celiac serologies, or looking for specific immune cells that are active in celiac disease and seeing if we can change them. And those are really important. I mean, we know as clinicians and scientists, and as patients, that having a healthy intestine is a really critical goal in celiac disease. So of course we want to measure that in trials, but we want to do that in a way that is minimally burdensome. So we don't want, people doing endoscopies left and right is obviously a challenge. But there's also things that are imperfect about that technology as well. We only are seeing a very small part of the small intestine. And there's a lot of artifact that can come in the way you read the biopsies. It's very, very challenging to do very good reads for trials of celiac disease biopsies, even though we've been doing it for a long time. So that's an example of biomarkers. I don't think there's any single perfect biomarker. I think we are fortunate that there's a lot of different biomarkers in celiac disease that measure different things about celiac disease, whether it's a TTG that measures the antibodies your body produces when people are exposed chronically to gluten, whether it's cytokines, inflammatory chemicals that are found in the blood after a gluten exposure, or whether, again, it's the intestinal damage that we see with more chronic gluten exposure, but is, again, slow to come on and slow to heal. So there are lots of different biomarkers. Often studies will assess at least one, if not more than one. But the type of biomarkers will really depend on the type of intervention. Again, going back to what we're trying to do, what we're actually studying. The other side of this is patient-reported outcomes, or patient-centered outcomes, as they're sometimes called. And these are surveys, to be simple about it. These are things like celiac disease symptom diaries, for instance, and these can be done most commonly these days on your phone or on a tablet device, but occasionally it can be dial-in or paper surveys, and they're going to ask you how you feel. So on a daily basis, and what symptoms they're asking about can depend on the type of the study. Some studies will be focused on the neurologic manifestations of celiac disease, so they might have more questions about headaches and fatigue and brain fog. Some questions are more focused on gastrointestinal symptoms, so they may have questions about nausea and vomiting, abdominal pain and bloating. And so all of these are really important. But obviously, there's a lot more to life with celiac disease than symptoms. And so another big part of the patient-reported outcomes are things like quality of life, social function. And these are another set of outcomes that we look at and endpoints that we can look at in certain types of clinical trials. Beyond just making someone feel better who might be having ongoing symptoms, do we actually make them live better? Are they able to do more in their life and be less burdened by a disease? And this is really a high bar. Obviously, it's actually not one of the things that is typically studied in a lot of other disorders. They really focus on, on more disease endpoints. Ulcerative colitis, if you're familiar, is a really good example, where really the studies predominantly look at inflammation in the colon and symptoms related to that. But the whole quality of life thing is a lot harder. In celiac disease, I think because there's such a high burden of just treatment with the diet for many patients, looking at quality of life and looking at the impact of therapy on the overall life experience is going to be really critical. And this is another big group of endpoints. So just to summarize, endpoints and outcomes in celiac disease trials or any clinical research is really critical. And it's important for you to know when you participate in research, what those endpoints are. And that's something you should feel comfortable asking any investigator about. Like, what are the outcomes in this study? What are we going to learn about celiac disease from this study? And then that should really help guide your interest in participating. So I hope that was a helpful, quick overview and introduction to celiac disease outcomes and endpoints in clinical trials. Thank you for your time and attention, and I look forward to answering any questions you may have.
Hello, my name is Kristen Neff, and I've been asked to come here today and talk to you about why I believe you should participate in clinical trials for celiac disease. I do have some experience on this topic because I currently work for Enochion, and we are conducting a study on a new treatment for celiac disease, but I've also worked at other companies that have done this. And more importantly, I have a daughter with celiac disease, so this means a lot to me. So what are the goals of clinical trials? They really are to find new treatments for celiac disease. And what can you do to help this? Well, what you can do is you can participate in a clinical study. So let's start with the basics. What is a clinical study? Well, they're really research studies to test new treatments and evaluate their effect on human health outcomes. They're carefully designed, reviewed, and completed, and they need to be approved by regulatory agencies before they start. The goal of clinical trials for new treatments is to determine, number one, is the treatment effective? And number two, is the treatment safe? Clinical trials generally have 4 phases, starting with the phase 1, which tests these new drugs in small populations of either healthy volunteers or patients to evaluate safety. Moving to phase 2, which tests to determine if the drug works and what the correct dosage is. And then to phase 3, which tests these new drugs in larger groups of people to really confirm if the drug works and is safe and to determine if there are any side effects. Most drugs get approved after phase 3, but they might go into phase 4 studies, which usually happen after approval, and they're really just looking at the drug in a much larger, more diverse patient population and over a longer time frame. So you may have heard of a website called clinicaltrials.gov. This is a government website that is a registry of all clinical trials. It was established in 2000 to improve public access to clinical studies. So if you search clinicaltrials.gov right now for celiac disease, you'll find that there are 260 celiac disease studies listed. 49 of those are currently enrolling patients, and 21 of those are enrolling patients in the US. 13 of those studies are interventional, meaning they're looking at new treatments. So you can see there are a lot of opportunities to get involved. So really, why should you consider participating in a study? Well, the biggest and most important reason is to accelerate time to getting new treatments. So right now, enrolling participants in clinical studies is one of the longest intervals in getting clinical studies done. Right now, when a drug begins development and the time it takes to get through to approval is averaging about 8 years. So the industry continues to focus on clinical trials. And if we can get clinical trials to enroll participants faster, that means we can get them done faster and we can hopefully get treatment options to patients faster. So since I've been doing this for a while, I do recognize that there are some barriers to enrolling in a celiac disease clinical study, and I wanted to talk about these with you and hopefully maybe answer some questions or give you some things that you can think about. So the first thing is that you truly do have to have a diagnosis of celiac disease. So most clinical studies require documentation of your diagnosis, which would include both serology, which was the blood test done when you were diagnosed, that identified proteins in your blood that indicated you had an immune reaction to gluten, and then also results from your biopsy, which showed that you had damage to your gut. They often also do genetic testing as part of the clinical studies to further confirm that you do have celiac disease. Now, I just want to note here that getting your medical records sometimes can be a real headache and require a lot of persistence on your part, but I just want to encourage you to stick with it and keep trying. State laws vary, but they do require that hospitals and doctors' offices deliver your medical records to you within 30 to 60 days. So you might have to make a lot of phone calls, but you should be able to get your hands on them. One of the other things you really need to think about when you're assessing clinical studies is the time and inconvenience. So you have to look at the visit schedule. Is there flexibility around the visit dates? How long is each visit? Do any of the visits happen on weekends or can they happen after hours? And then ask questions about what happens at each visit. Are there clinical assessments? Are there any procedures that are going to be done? Are samples going to be collected? Are there lengthy observation periods when you'll be waiting and they'll be observing you? And then what will happen in between visits? Do you have to complete a symptom diary at home? Are you going to have phone calls with the staff? Will there be remote study visits where somebody might come to your house? And finally, make sure you ask questions about compensation because most clinical studies do offer appropriate compensation for your time and travel. And it's important to know this when you're making any commitments. So really ask all the questions you need to ask to make sure you understand exactly what's going to be done. The other thing you may have heard about in clinical studies for celiac disease patients is gluten challenges. And I can understand how just the thought of that could be scary for a lot of people. So I just want to make sure you understand why these gluten challenges are in many clinical studies. As you know, eating gluten triggers an immune response in celiac disease patients. So one way to test if new drugs work is to have patients take the drugs, and then after that, have them conduct a gluten challenge and see if their immune response is the same or if it's changed. So typically, these gluten challenges are not long. They're not like the one you may have had when you were diagnosed, which was probably a couple of weeks long and really intended to cause changes in your bowel so that they could detect these when they did a biopsy. The gluten challenges in clinical studies are often much shorter, and they're really not intended to cause any changes in your gut. So how do these usually go? Well, typically you get to ingest a specific amount and form of gluten. Unfortunately, it's not usually a cookie or a donut. And you do that in a specific amount of time. And then the clinical site will collect blood samples to measure your immune response to the gluten. They may also ask you to fill out a symptom diary for a specific amount of time. And what you should expect is really that your symptoms would be similar to what you experience when you inadvertently are exposed to gluten. The other thing you definitely want to ask about if you're considering a study with a gluten challenge is, can you get treated if you do have bothersome symptoms? And many of these studies will actually give you treatment so that you do not have to be uncomfortable or suffer. So even thinking about all of those things, there's something else we have to layer on right now, and that is COVID. So I just want to share a couple facts about COVID, and I've got some references here. The risk of contracting COVID for patients with celiac disease is not increased. And as of right now, there have been no studies or reports that suggest that patients with celiac disease are at any increased risk of severe illness from COVID. But COVID is a real concern and something you absolutely have to consider and take very seriously. But you should know that clinical sites have done a very good job to do everything they need to do to keep both themselves, their staff, and their patients safe. This is their business. So when you're considering a clinical study, you should talk to the staff at the site and make sure you fully understand what their COVID safety precautions are. They should be able to tell you if there's COVID screening or testing, what kind of PPE are required, what their social distancing practices are, and how they make sure that you are not exposed to any other patients they may have participating in other studies. At the end of the day, I think you'll find that most clinical sites are doing an excellent job, but of course you should not move forward and participate if you're not comfortable. So that's just a very quick overview of some of the things you should think about. And so now you can ask yourself, should you participate in a clinical trial? So I am going to encourage you to say yes. Number one, clinical trials are necessary. They're a required step to bringing new treatments and research to patients. And these trials can't happen without participation of volunteers. Number two, clinical trials help others. Your participation in a clinical trial may not directly benefit you, but we are learning more about research for new treatments and also helping to better understand the condition. Number three, clinical trials can help your loved ones. So some conditions like celiac disease have a familial component. So your participation may end up helping your loved ones by making new treatments available later and advancing scientists' understanding of celiac disease. Clinical trials may give you access to new cutting-edge treatments. And of course, you will also have access to a medical team that's going to be carefully monitoring your disease and your overall health for the duration of the study. And finally, clinical trials need participants from all backgrounds to participate. It's important that new drugs are studied in a very diverse patient population. So whatever your age, your race, your gender, or your background, you are still needed in these clinical trials. So hopefully I've given you a few things to think about, maybe answered a few questions, And I just want to finish by thanking you all on behalf of all organizations that are currently conducting celiac disease clinical trials.
Hi, everybody. I think you've had a few minutes to digest this great information from our colleagues in drug development. And I hope you have a lot of questions. I see I've been monitoring the questions coming in here over the last 45 minutes. And I have noted some questions, and I'm going to direct them to our distinguished colleagues on our panel. But I know some of you on the panel also have questions you'd like to ask. So I think based on the number of questions that I've seen, the number one question that everybody wants to know, and I'm going to throw it out there to the three of you, Francisco, Dan, and all of you to think about, what is a realistic timeline that celiac patients can expect a pharmaceutical medication to pass all trials and become widely available? Ben, I know you wanted to answer that live too, so hopefully our panel will cover what you were planning to say. So Francisco, I see you're jumping in for this one.
Sure, I can do that. Good afternoon, everybody, or good morning. I do want to say I've listened to hundreds of celiac symposia before, and this was one of the best I've ever listened to. I was so impressed with Jennifer's, Dan's, and Kristen's presentations. They were practical and to the point, so thank you very much. With regards to how long until we have a drug on the market, as you saw, we now have at least one drug in phase 2B, one drug in phase 3 for symptomatic relief. So once you are in this advanced stage, you could reasonably expect a drug on the market in 5 years, plus minus, generally plus 5-6 years. But that is assuming that these drugs will actually make it. And that's not a given by any means. So that's why we often disappoint you telling you a drug is 5 to 10 years away at every single meeting. It's because the high attrition, the high failure rate. But I do think we have critical mass. You saw the slide with so many companies working on this, and the great work done by our colleagues here today at Immunogenics, Takeda, Anokian, and others, prevention. So we're really working hard to shorten those timelines for you. And hope is the word of the day.
Okay, thanks, Francisco. There were a lot of questions I saw around the age requirements for the various clinical studies. And I'd like the three of you to maybe offer some insight as to why is there a cutoff at 70? Why is there a cutoff at 18? And why are there any under 18 studies planned or ongoing? And for some of the older folks, they know a lot of people with celiac disease, and why are they not able to help to find a cure?
This is Kristen. Hi, I can take a stab at that and let my distinguished colleagues jump in. We are in early phase, and in many early phase studies and in most conditions, they limit the patients to an age limit that reduces risk, because phase 1 studies are the first time these drugs have been introduced to humans, and it's important to reduce risk any way you can. And one of the ways to reduce risk is to keep the age limit at 70 or even below 70. In terms of less than 18, those are pediatric studies which require different levels of regulatory approvals before you can begin, and different sort of are already having some efficacy or safety established. And so those trials do come, and they will come, but they generally are not early trials. They are later on in development of these drugs. I can let my colleagues jump in.
Anybody?
No, not a lot to add to that. I completely agree. I just want to actually go back a little bit to Francisco's response. I completely agree 5 years is a reasonable estimate. I think there was two parts to your question though, Jennifer. One is when will a drug be approved and when will it be widely available? And we know now in the type of insurance environment we live in today that approved and available aren't always the same thing. And I think that is something that the community needs to be aware of. And I know the Celiac Disease Foundation is already doing a lot of great work in this area because I don't think it's a given. And right now, insurance companies do not appreciate celiac disease as a disease needing further therapy. And that's something that we do need to focus on as a community so that when an effective drug becomes available and approved, people can actually get it and they're not ridiculous insurance barriers set up in front of actually prescribing this. And I do think that is a concern that we all have.
Thanks, Dan. A lot of questions came in about dermatitis herpetiformis. Can any of you comment on, are any studies planned or ongoing that will study that part of the celiac connection?
Yeah, I can go. Sure. So I think, celiac disease is such a heterogeneous disease and it manifests in so many different ways for so many different people. I do think that there are many studies that are sort of planned and in conception, thinking about what other types of manifestations of celiac disease beyond GI symptoms we can look at. And dermatitis herpetiformis is an obvious one because it's an easy thing to measure. Skin, it's on the skin. There's good examples from psoriasis and atopic dermatitis of how you can evaluate in an objective way the degree of skin lesions. So I do think that is going to be something that people begin to think about therapies for. But I think that uncontrolled dermatitis herpetiformis on a gluten-free diet is relatively uncommon. And so at this point, it's really the idea that that's not as large a population as some of the others types of active celiac disease on a gluten-free diet that's sort of limiting people's, the speed at which we go into dermatitis herpetiformis. But sorry, Francisco, I think you were going to say something as well.
Yeah, no, similar to your response. First, many trials do not exclude dermatitis herpetiformis patients. So if you see a trial for celiac disease, double check, because at least the trials I have been involved with did not exclude DH. So you can participate. And it's true that there is a concern about exposing patients with DH to a gluten challenge. Sometimes gluten challenge trials exclude DH patients because they can get really uncomfortable for them. But be active and check out for the trials.
Along that note, I've also seen people wondering why they've been turned away for other conditions such as IBS. Why can't people with other conditions be accepted in clinical studies? Could you all comment on that? I know it's very study specific, but
yeah, comments? I mean, I'll just jump in. One of the reasons is because they may confound any results that you might see from the drug you're studying, especially if the condition has similar symptoms to the condition that you're studying. Also, like Francisco mentioned, if you know that parts of your study might trigger suffering or discomfort from your patients or make them sick in some way, like with dermatitis herpetiformis, you would want to exclude those patients. And then again, it's really to reduce risk and to try and keep the variables very limited that you're studying so you can actually get some clean understanding of the drug you're looking at and the condition you're looking at and whether there is any benefit there.
Okay, thanks, Kristen. Along similar lines, patients or people have been asking, why am I turned down because I don't live near the research sites? And also I'm reading concern about COVID and going to the research sites. Are any of you aware or part of your studies that are going to be done remotely to help this both of these situations?
Can I make a comment about that? I think most studies are very careful about removing travel concerns from the equation. That is the least worry we want to have. So for example, the prevention studies will pay for you and the chaperone if necessary to travel to a clinical site every visit, hotel, wherever is necessary. We will send a car to pick you up to your home and take you to the site. So clinical research is so difficult and patients sacrifice a lot of their time and they take a risk. Travel should never be a concern. So please don't ever hesitate joining a trial just because of a concern about travel, because we'll take care of it.
Thanks, Francisco.
I also
I think
just that, oh, sorry, go ahead. Sorry, Jennifer.
Okay, go ahead, Dan.
No, I was just going to say that this is also, I think COVID, one of the silver linings is that it has really forced a lot of innovation into research. And one of those is really around remote visits and virtual clinical trials. And I think, you know, all of us are working to include those in a way that was very challenging from a regulatory perspective and just from a sort of an overall risk management perspective before. So I do think in future trials, we are going to see a lot more potential for visits that do not require site visits to the actual site, things that can be done at home, sending a phlebotomist, doing more things virtually, really, which I think overall will improve and reduce the burden and make it more possible for people to participate in our trials. I'm very optimistic about that.
Yeah, if I may add, indeed, the proactive study that we're conducting, we offer half of the visits at home with a mobile phlebotomist. Unfortunately, many of the investigators don't like it and they don't offer it to their patients. So we are fighting cultural barriers at multiple levels. And symposia like this one are so important so that we put our challenges on the table and how to address them. But indeed, we need to move to a more virtual setting, more remote setting, though always some visits will have to be done at the site, for example, when you collect biopsies, etc.
Thanks, Francisco. Dan. I think that further, Dan, to your points about ask questions when you're signing up. There's a lot of studies out there that are recruiting. Ask which ones fit you. You know, which ones ask, is there travel? Is there compensation? Is there, you know, whatever that you think will make, you know, turn your head to say, yes, I'll participate in this study. So this is a good resource to ask a lot of these questions now so that you'll be educated when the opportunity arises to pick one of these studies. Okay, next question is, I think for Dan. You mentioned that interpreting outcomes from endoscopies is inexact. Why is reading endoscopies for clinical trials so difficult?
Yeah, so it's actually reading endoscopies at all is difficult, not just in clinical trials. Reading biopsies is really an art. And if you think about, you have an intestine that's 20 feet long and you're taking a couple of tweezers and pulling off a few teeny pieces, you're really not getting a sense of the overall health of the intestine. Plus, villi are floppy, right? If you imagine little leaves of grass, they're really hard to measure and understand if they're short because they're bent or short because they're actual blunted because of celiac disease. So it's just, while it is fine for just making a diagnosis, yes or no, beyond that is a very tricky technology and one where I think we need to continue to improve and look for alternatives and adjunctive tests.
Okay, we have time for one more question.
No.
And again, sorry. We have time for one more question, I think. And that one, I've had a lot of questions about, well, I have symptoms, but I didn't get the biopsy. I got serology tests done, but I didn't get the biopsy. Or I was turned away because I didn't have a biopsy. Is there a general way you all could address the various stages of diagnosis that patients have and maybe help them to better understand why they need or why they don't need a biopsy, as well as serological confirmation of the disease?
I'll just say that it's critical when you're studying a treatment for a specific disease to establish that the patients in the study have the disease. It would be very difficult to assume diagnoses based on symptoms and other medical history, especially after some of the talks we heard earlier today that indicate that it could definitely not be celiac disease. That would slow down our ability to truly study these medications and see if they work.
Okay, thanks, Kristen. And sorry, I can't let the other two of you join in on this, but I'm told we're out of time and I don't want to hold things up. Thanks so much to our panelists. Really, really, really great presentations, and thanks for answering our questions. Anybody who didn't get their question answered now will get a written response at some point. So with that, I'd like to sign off and welcome the next session.
Thank you.
Thank you all.
Hello, my name is Lisa Stewart, and I'm part of the public and patient engagement team at PCORI. Our team's work supports researchers and partners funded by PCORI in realizing their engagement goals, and we work on projects that facilitate stronger engagement and partnerships through building an evidence base, developing resources, and sharing information about engagement practices more broadly. I'm pleased to share with you in this presentation a brief overview of PCORI and a snapshot of what we've learned about patient engagement thus far. PCORI's mission is to help people make informed healthcare decisions and improve healthcare delivery and outcomes by producing and promoting evidence-based information that is guided by patients, caregivers, and other healthcare stakeholders. We do this by investing in research studies, investing in projects, activities, and resources that support research and the dissemination of findings, and creating products that synthesize and map existing evidence. PCOR, or Patient-Centered Outcomes Research, places a tremendous value on the lived experience of patients and caregivers and other stakeholders. It is our belief that engagement improves the trustworthiness of research and its ability to be implemented more quickly. PCOR brings together two concepts, patient-centeredness and patient engagement, that are critical and interrelated. Patient-centeredness, as we think about it, is the extent to which a proposed study, question, and outcomes are of importance to patients and their caregivers. The extent to which interventions being studied are accessible to patients and stakeholders, and the extent to which participating in the study is minimally disruptive to study participants. Patient and stakeholder engagement, as we think of it, is an intervention that helps studies achieve patient-centeredness. From a patient or patient organization's view, it is the process of partnering with researchers and leveraging your lived experience so that research is more relevant and pragmatic. What have we learned? When PCORI began and first established engagement as a requirement, there was no evidence that engagement made a true difference. There was also little guidance on how to do it. We were intentionally non-directive to encourage creativity, to allow PIs and research teams to best determine what would work for them. Since those early days, PCORI has learned a lot taking advantage of our rich and varied portfolio to learn about engagement practices in different settings and different contexts. The information I'm about to share represents a synthesis of practice-based learnings, data taken from project monitoring and surveying and interviewing funded researchers and stakeholder partners, and the results of a large-scale study that included 120 in-depth interviews. We are learning that engagement is, in fact, making a meaningful difference. We now have evidence that what we originally hoped for about engagement is actually occurring. We know that engagement is influencing how a study is conceptualized, how it is implemented, the study materials used for recruitment and training study staff, and is influencing the design and implementation of engagement itself. Overall, researchers are developing a much fuller understanding of the needs and concerns of stakeholders. In one study, for example, that looked across 58 projects and included 1-hour length interviews with investigators and stakeholder partners, there were recorded more than 400 distinct examples of how engagement influenced study conduct. One thing that we know for sure is that one size does not fit all. Engagement can look different in different partnerships. This picture shows different levels of involvement without value given to any particular one, from patient and stakeholders providing unidirectional input, that is, not engaged as ongoing partners, to patients and stakeholders functioning as partners, occupying roles of increased responsibility and increased involvement in decision-making. Within studies, we may find all of these forms operating at different times or at the same time. In our research study, we saw teams travel along this continuum based on a task at hand. It could be that a focus group is needed for a specific task and patient or stakeholder leadership is best for others. The big takeaway here is that engagement is iterative. It is dynamic. It involves flexibility and often requires different methods to reach different groups. Another way to consider the effects of engagement is to think about its impact. In an earlier slide, you may recall we looked at what is being influenced. Again, study conception, execution, the broadening of knowledge of stakeholder interests. This slide now shows us the impacts, or that so what, from the standpoint of patients and researchers in another useful way. Our large-scale study showed evidence that engagement has these impacts. It has an impact on user orientation and acceptability. This refers to a patient's willingness to participate in a study based on the burden, the usability, and the alignment with their own preferences and values. Its impacts are felt in the feasibility. This means how doable the project is in a real-world setting. The impacts extend to study quality, which takes into account the rigor and the comprehensiveness of the study and the quality of materials and products of the study. It impacts the relevance, which refers to the applicability of the results and its importance for patient decision-making. And it also impacts the scope and quality of the engagement itself. Now, moving beyond the research projects and looking at benefits that accrue to the people and organizations involved, you see here some of the findings from a qualitative study of Macquarie research partners and what they reported in terms of benefits. On the individual level, patients reported, among other things, that their experiences with engagement resulted in more enthusiasm for research. It resulted in them acquiring new skills and professional opportunities. It resulted in a better management of their own health condition. They were rewarded with relationships that lasted beyond the study itself, and they felt an overall satisfaction of feeling like they were making a difference for future patients. We heard from community and patient orgs that engagement helped build trust with other stakeholder groups, and it strengthened those relationships and increased their awareness of different stakeholder perspectives, and at the same time increased their capacity to do research again. This slide categorizes the types of challenges shared by patients. So while there are many rewards, there are challenges too. Engagement can be hard and difficult. It requires bringing a multiplicity of perspectives together. And so what you see here are a number of areas that have been categorized around those challenges to help us categorize those challenges. So within infrastructure and resources, this refers to how do people, or what is the knowledge and skills that people need to actually partner? What is the burden of time? What is the burden upon resources? Does your organization or you as an individual have those resources to spare? On the level of people and teams, what we know is that there are many questions around access that need to be addressed, as well as ensuring that diversity and inclusivity happens. So we should ask ourselves, who, patient partners should ask themselves, who are you representing? How have you ensured to bring in other perspectives other than your own? And how will you extend the reach and bring those perspectives into the room? We also know that there's many challenges for organizations and that there's an ongoing challenge of balancing the many different perspectives such that you avoid, or the team avoids, conflict and that they hear each other's concerns. We also have evidence that PCORI's approach to engagement is influencing the culture of healthcare research more broadly to be more patient-centered by inspiring and catalyzing changes at other organizations and institutions. Here are some of the activities that we see occurring now. You see more seed funding for partnerships, more trainings available for students and research partners, more opportunities for patient partners to be reviewers in the application process or in manuscripts submitted to journals. We're also seeing just a much more wider spread adoption of policies that support and encourage engagement. In closing, what also has been validated in our research is that engagement requires careful planning. When a patient or patient organization and researcher decide to partner, they embark on a journey together that can take up to a year or much more to go from conceptualizing a project to submitting an application for funding to learning if that project was funded or not. And an application to PCORI was described for engagement may be very high level or based on an ideal scenario that has changed from the time of award. PCORI thus requires awardees to submit, after they've been awarded, a startup plan, a very detailed plan for how engagement will be operationalized and set itself up for success. This slide contains the key areas that we ask about to get to when a project stands up their engagement infrastructure, what could be helpful as guidance for anyone who is planning an engagement strategy. It's always helpful to think about the goals, who's represented, who's going to be coordinating engagement, how are you going to manage the engagement governance, and how are you going to structure it, as well as what do partners need to prepare. And lastly, I want to point you to resources that are available on PCORI's website. Please use them liberally and share them generously. Building a more inclusive culture and research takes the will and the participation of many. I wish you much success in all your efforts in helping us to collectively reach that goal. Thank you.
Hello, my name is Kelsey Smith, and I was diagnosed with celiac disease in 2016.
Hi, my name is Andrea Monroe. I'm from North Carolina, and I was diagnosed with refractory celiac disease in 1996.
Hi, my name is Jennifer Hale. I have celiac disease. I was diagnosed with celiac disease at the age of 16, so I'm going on my 14th year.
Hello, my name is Elizabeth Kearney. I have celiac disease and I was diagnosed about 10 years ago.
Hi, my name is Kelly Maynard. I live in St. Paul, Minnesota, and I have celiac disease. I've had celiac for about 5 years. That's how long I've known I've had celiac, I should say. And I did take part in a drug study that ended about a year ago, shortly before the pandemic lockdowns began.
And the reason I want to participate is because I want to help. I want to help patients who are like me, who feel helpless and who feel like they're not being heard. And I want to help patients whose doctors don't know a lot about the disease. And I want to give them a voice. And that's one of the reasons that I participated. I want there to be a future for future celiac patients, not to have to go through what I went through.
I chose to participate in a study because I saw a lot of emails about the same study over and over and over again. And so after, a couple dozen emails came through, I clicked and I started reading on the website. And it was so easy to understand exactly what was expected out of the participants and exactly what they were trying to achieve with the study, that it really motivated me to want to participate. But the clincher was definitely the fact that you would not have to ingest gluten. Having the transparency of the risks and the exact involvement up front, rather than having to ask questions or dig, really helped me relieve a lot of anxiety because I didn't have to worry that there would be any surprises or something I wouldn't be comfortable with.
Some of the reasons I did this study were, self-preservation, trying to improve my quality of life. But celiac disease runs heavily in my family. Both my parents have a genetic variant of the disease, and I inherited both. And then, my niece has it, my cousin has it, my grandfather passed away from complications of having it, which we didn't know until later. So when I did the study, I did it thinking I'm not only helping myself, I'm helping my family. And I have a number of friends with celiac disease. So I was really thinking I was helping more than just myself.
I did it because my 2 sons have celiac, and honestly, none of us have any difficulty with managing the gluten-free lifestyle. It comes fairly easy to us, and we're all healthy and have fully recovered. But I do get concerned about when my sons leave my house and start college and are on their own for the first time. So I'm doing it more in terms of their future.
I've had a pretty good experience with the couple of clinical trials I've participated in. I definitely would say that some involve doing a gluten challenge, and those I was a bit hesitant to participate in, just because I'm extremely careful with my diet, and the idea of intentionally eating gluten was a bit scary. But once I learned how just exposing myself for a short time may benefit celiacs, I was willing to take on the challenge.
I felt very welcome in the drug trials that I participated in. It seemed that all of the doctors knew what they were talking about. All of the associates who helped with the drug trials, who helped me with recording my information, were wonderful. And it made me feel like my disease is real, and it made me feel like I was being heard. And that is something that I don't feel a whole lot.
The only, I'd say, difficult piece of the research project for me was the scheduling. And that was because this particular study involved 5 different visits, and they were all very specially timed. Like, there had to be 4 weeks between 2 of them. And the scheduling was pretty restrictive. So that was a bit difficult to figure out.
Now, unfortunately, I have not yet participated in a clinical trial, even though I have been attempting to participate for several months now. And I think that just speaks to the larger organizational issues that may be facing these trials, and trying to gather and connect to people, especially during a pandemic. I have been actively engaged and reaching out to this clinical trial to try and participate. And I think just because of coordination and being unable to get back in touch with them correctly, I have not been able to actually formally enroll. And for me, I have been proactive about it, but I can imagine that if someone had signed up for a particular study and then just never heard back, they would simply say, oh, I guess I'm not qualified and not participate. And that can absolutely dramatically reduce the number of participants we have. If you finally have someone who's committed and who wants to get engaged and who is ready to make the drive once a week, every week for 9 weeks, then having them drop off, trying to re-engage them is probably close to impossible.
One thing I would have really liked to have known was to be updated on how the clinical trial was going. I don't know if legally that's possible, but it would be a really cool addition to participating.
Participating in that study was such a positive experience that I had, and it improved my life so tremendously. One of the frustrating things is that I haven't heard about it being released out into the world yet.
So for those of you who want to participate, I would say be patient and don't be afraid to reach back out. Even if you are just speaking with a screener who is not necessarily part of the study site, the screener can get you in touch with someone who knows more information, and they can keep following up the chain until you reach someone who can reaffirm that you are enrolled and make sure that you can participate.
I also would remind anyone who's considering taking part in research that you're really in the driver's seat and that it's your choice and you're in charge. And if there's any part of the process that you're uncomfortable with or uncertain about, or you want to quit, that's your prerogative at all times. So you are in no obligation to finish a study that you begin or take part in any labs or any other procedures that you're not comfortable with. So it really is, it's all about your preferences and what you'd like to get out of it or add to it.
And it was an honor and something that I felt like I had a voice in that made me feel like I was empowered. And I think that's why these drug trials are really important.
There would never be a drug that would make it to a clinical trial if the benefits didn't outweigh the risks. And I think really driving that point home can really draw in a lot more participants and really help us to not only alleviate symptoms, but to cure celiac disease.
Hi again, Jennifer Voigtsener. Thanks to all the patients that shared some really insightful experiences, good or bad. Really, it's, you know, if you share something, everybody else, I'm sure, has had a similar experience or, you know, is helping them to decide what they would like to do, which trial to sign up for. So for the remainder of this session, we have 6 biopharma panelists that would like to introduce themselves and ask the patient participants some questions. And so we're all going to have 5 minutes. And I'd like to start with Patrick Griffin. And if you could introduce yourself briefly, and then feel free to ask your questions. Patrick here. Well, if he's not here, I guess I can go on to Dan Leffler.
Yeah, thanks. I'm here. I guess my question just to start off would be, if somebody was on the fence about doing research, you had a friend or somebody, is there one piece of advice you could give them that could help them feel more comfortable with the process? Is sort of one sort of words of wisdom to offer?
Anybody can jump in on the patient side.
Well, I'll speak if you don't mind. I would tell people, they're not going to force you to do anything you're uncomfortable with. and be your own advocate. Speak up for yourself. If you don't like what they're asking you to do, then ask if there's another way to accomplish those results, or decide to back out of the trial, which would be unfortunate. But if you don't try, if you don't speak up for yourself, then you might find yourself in a position you're uncomfortable with. So be your own advocate.
That's exactly right. That's something I would say as well. If you don't feel comfortable with something, ask about it, or just voice that you're uncomfortable. And the trials I was in, I found that they really listen carefully to what you have to say and respond and explain things to you. And so they made me feel very, very comfortable. And I dealt with the same people pretty much every time I went. So it's kind of like you become familiar with them. And the same with the doctors. I actually went and sought out one of my doctors that I was in a trial with after, because he was just amazing. And I knew that he was a researcher who did research on celiacs. So it's, you get to meet a lot of influential people as well, like doctors that you might not be aware of that might help you as well. So talk to those doctors and tell them, hey, I'm concerned about this. And they're very forthright and forthcoming and very helpful. So.
I'd also add, during the course of the months that I was involved in a study, all of the staffers made me feel very appreciated, and I was very well treated, and it was pleasant. It was very pleasant all the way through.
I would tell anyone interested to trust the experts. I really believe that we wouldn't be opening these trials to patients if there wasn't a lot of trust and there wasn't already a lot of preliminary research. They have our best interest in mind, and they wouldn't be putting us at risk, if there were a lot of known risks. So yeah, life's a risk, and having celiac, you're always at risk. So why not take a chance at something like this?
We have a couple more minutes. Anyone else would like to speak to Dan's point?
Sure, I can chime in here. What I would say is, if you are on the fence, then ask questions. What are you on the fence about? And ask about it, because as soon as I started asking questions about the drive time, for example, or the location, or what would be required out of each visit, I got all of the answers I was looking for. And so I was then able to make those judgment calls about whether or not I actually wanted to continue, because I got those answers addressed. And in the moment, it felt like, well, maybe I should just know this, or maybe I'll just go along for the ride. But it's all up to you. You're as has been mentioned, you're in the driver's seat. So even though you are participating in something that you are not currently aware of, you have to take that ownership of saying, like, I'm not sure about X, or I'm not sure about Y. Can you give me more information? As soon as I did that and I received that information, that is what allowed me to say, yeah, I want to do this, and click the button.
Excellent point. Speak up, I guess, basically is your point. And don't be afraid to ask questions. Never a stupid question here. Okay, anyone else before we give Patrick another chance to introduce himself?
Can I follow up what Kelsey just said, just very briefly? Sorry, Patrick, coming to you in a sec. Sometimes don't hesitate to reach out to the company directly, because we work with a lot of intermediaries, middlemen, right? Companies are not allowed to know the identity of patients who are already actively participating in a trial. So we work with clinical research organizations and with the sites, and they may not know all the answers. They may not have the same kind of passion that we have for this. So don't hesitate to write to the informational email of each company that you're interested in learning more, and you're gonna get attention. You're gonna get people like Dan or like me or like Kristen. We're all gonna be responding to your questions. It's just, we cannot know what you do with the information afterwards for ethical reasons and privacy reasons, but we will respond to you.
Thanks, Francisco. Thanks, Dan. We're gonna move to Patrick Griffin. please can you introduce yourself and ask our patient panelists what you'd like?
Thanks, Jennifer. Can you hear me now?
Yes,
okay,
I can.
Great. My name is Patrick Griffin. I'm the Chief Medical Officer at 9 Meters Biopharma in Raleigh, North Carolina. And we are in the middle of our phase 3 trial with lorazepam acetate for the treatment of symptomatic celiac patients already on a gluten-free diet. One question I wanted to ask, and I know that it was a mistake not having my microphone working because now all the good questions have been asked. So the one question I would like to try to understand a little bit is, how do patients feel about a drug that treats symptoms? When you're on a gluten-free diet, you do the very best you can. I don't think any of us truly understand, why patients who are adhering to their gluten-free diet have symptoms. But do you have any special feelings about a drug that treats symptoms versus a drug that is attempting to sort of modify the course of the disease? Anyone can answer.
Go ahead.
Go ahead.
I would say I'm rooting for that drug more than anything else. Having celiac for 14 years, I don't see myself ever giving up a gluten-free diet. And I think that would speak to a lot of celiacs, especially just with dietary trends. But we're always exposed to symptoms. I think everyone spoke to this today, cross-contamination, we'll always be battling that. So to have a drug that just alleviates symptoms, like that was number one goal for me in participation.
Yeah, that's what I was going to say too. I mean, a cure would be fantastic, but I have symptoms pretty much daily. And when I was in a drug trial and the drug actually helped me, I told my husband that I went for a walk, and for the first time in years, I didn't have a stomach ache. And to me, that was just like a miracle. So yes, we cannot get a cure helping with the symptoms, because right now we have nothing for the symptoms, nothing. And so yes, absolutely, that would be worth so much money to me.
Mm-hmm. I agree as well. Yeah. I mean, I was down to 95 pounds and eating a clear food diet for 2 years before the trial I did. And afterwards, I was actually able to start eating more foods. I still can't eat dairy. I don't eat meat because it's gross to me. But I have a very limited diet. And so if I had something that alleviated some of the symptoms, maybe I could eat something more than salad. That would be lovely.
I was actually interviewed by a pharmaceutical company, and they asked me if I was to buy the drug that just treated my symptoms, would I, how much money would I be willing to pay? And would I use the drug just to eat what I want? And I thought, no, you've obviously never been a celiac patient before, because I don't understand why anyone would do that. No, I would still stick to my gluten-free diet, but, and I told this pharmaceutical company, I said, I shouldn't tell you this, but I would pay a lot of money. I don't care. Like I would buy that drug. And I shouldn't say this. I should say, please charge us only $10. But I would. I don't know many patients who wouldn't, honestly.
Thank you.
And I would just say, like, personally, yeah, I want to treat my symptoms right now. So if you're asking me in this moment, what do I have, 1 or 2? I say, yes, let me treat my symptoms. But if I'm thinking about the long-term needs of the celiac community, and that includes patients who can't afford gluten-free foods, who can't afford gluten-free education, who can't afford dietitians, I'm thinking the cure is the only long-term solution. Yeah, sure, I would love you to invest all of your money in making me feel better right now, because I don't feel great. But honestly, like, I am in a position where I can afford all these things, and I can accommodate my gluten-free diet. And so when I think about if I want to participate in something that's going to make an impact on the celiac disease as a patient, for me, I would be looking into how can I impact the journey for everybody. And so many patients just, even if treating their symptoms in the moment might feel better, long term, the damage is still happening. The damage is still occurring in our intestines. We are still going to be facing long-term health complications because of the issues going on, even if we're not physically feeling the symptoms that might be associated.
That's an excellent point. I'm on a social media site of like a celiac forum, and there are people on there all the time who speak about how they can't afford to buy gluten-free foods because they've run out of money at the end of the month, and they just have to eat what's in the house in their home. So that's an excellent point.
Well, thanks all of you. I'm sorry, but I'm going to have to give the floor back to Francisco. Patrick, I hope you got your question answered. Thanks.
Yeah.
Francisco, the floor is yours again.
Well, I only have one question actually left because most have been addressed. It's in regards to the comment by Elizabeth about not knowing what happened with the study results after the trial was over. And I think this is a very important point, that we as an ecosystem are a bit delinquent. Sometimes we provide a lot of information before the trial, and then after the trial is over, we get busy and don't share back. So a question for the patients and a question for CDF, should we think about solutions for this problem? Should we have a dedicated page in the CDF website where we would provide information of what happened with the studies after they've been completed?
I think so. I mean, if there is a way to find out, is that drug available? Yes, I would ask my doctor to prescribe it to me, but it's been, let's see, 7 years since I did the trial. And as far as I know, it's not available. There's nothing available.
Right. So perhaps a page where a summary of the trial results and what the status is of each program. There may not be a single repository of information. So
I would read it.
Yeah, and I think it could. I was just going to
say this is. Oh, sorry. Go ahead, Kelsey.
It would just be important for people who are also on the fence about these trials. So if you don't know much about what's happened in the past, or you're nervous about what could come out of it, having as a patient, seeing what has actually already occurred and the benefits that came out of that would absolutely push me further into wanting to participate.
And this is Beth Ann Reedy. I'm with GlaxoSmithKline. I'll be speaking in a few minutes, but I just wanted to address that. Many times, and maybe patients aren't aware, sometimes that's posted on clinicaltrials.gov after results are completed. Now, sometimes if you've been an early participant in a trial and it's not completed yet, the results might not be out there. But, to your point, Elizabeth, if it was 7 years, you should have been able to obtain some information. At Glaxo, we are committed, and we have a policy internally to publish our clinical trial results within a year and a half. It does seem like a long time, but after a trial completes, we have to get all the data in and complete out a report. But there is the obligation within some pharmaceutical companies, particularly GSK, that do publish it.
So this is Sarah. I'd like to jump in for 1 second. So we do have at celiac.org a page called Future Therapies, and it does talk about what's in the pipeline. And for those trials where we know what has happened, we do post back, for instance, when Imusanti had to discontinue their trial. But we would be very pleased to be able to post whatever information is out there at the website for everyone, because it would be up to our partners to provide that to us. But absolutely, we'd be very happy to update that page with all trials and where they are.
And I know that I've heard a few things on the news about my drug trials that I've been in, but not many. And I know, a lot of people don't get their information from news sources anymore. They get them from social media or, social media groups. Or so even, putting something like that out there on a celiac support website or something like that would also draw maybe some possible future people who'd want to participate. And it would also, update the community on what's happening and get them enthusiastic about it. So I think that might be another option as well.
Thank you.
Francisco, any other questions you'd like to ask? Nope. Going.
Sorry.
Okay.
Appreciation for all the testimonials from all the patients. You guys rock. Thank you.
Thanks, Francisco. And now I'd like to introduce John Lynch. John, would you like to take the floor?
Thank you. Hi, my name is John Lynch. I'm a gastroenterologist at Janssen Research and Development, which is an arm of Johnson & Johnson. And we're relatively new to the celiac disease research arena. But I want to assure you today we're very committed to moving into this area. We have a wealth of research experience, clinical trial experience in a number of other immune-based diseases such as Crohn's disease, ulcerative colitis, rheumatoid arthritis. We have a pipeline that's coming up where we have a lot of more specific agents, very safe, that we are very interested in seeing how well they will work in other diseases such as celiac disease. In fact, our first proof of concept study will lift off later this year. It's called Spotlight, so please do look for it. And that leads me to my first question, which is, how can we reach out to the celiac patient population to let them know about this trial? Clearly, working through the Celiac Disease Foundation here is one avenue, internet is another, but we're looking for any ideas that you might have to reach out to patients. So newsletters,
I mentioned even just leaving pamphlets at doctors' offices, because I don't ever see anything at doctors' offices, especially gastroenterologists. It would be nice if I go for my yearly checkup or even my, anything, testing that I have to have done, to have some kind of pamphlet or some kind of resource there, so that future patients or new patients might be able to see that, because I know how bad it felt not knowing what to do and where to go when I was first diagnosed 25 years ago. So
great.
I can't even imagine. It would be amazing, even just
Andrew's breaking up.
A little bit. Ooh, yeah, your voice is breaking up a little bit.
Oh, I was finished.
Oh, okay. Anybody else?
Sorry.
Sorry.
I would suggest promoting it on, if you were to partner with any gluten-free foods, and posting it on, like Char brand or anything of the sort. Just because I know I get an influx of emails. I try to stay up to date with anything from celiac.org just because I'm invested. But yeah, I think that posting on food labels, I know I'm always reading, anyone with celiac reads every ingredient, every food label. So I think that would be a great way to catch their attention.
I think that's a great idea. I thoroughly read every box multiple times just in case.
There are also established Facebook groups with thousands and thousands of celiacs, because we are always looking for ways to connect with each other. And there are ones for areas of the country. So if you're looking for specific areas, there are ones for different age ranges, for different interests. They're already in groups. They're already reading their posts every day. So that's a really excellent resource. Additionally, there are a couple of different apps that celiacs like to use, like Find Me Gluten-Free, amongst other things that you can advertise on, that we often are going to on a very regular basis. So that is another area, whether it's, to to Jennifer's point, whether it's like on a website for Char Foods, or it's on, the Fody website, or whatever gluten-free brand already exists. We're reading it, we're looking at it, we're talking to each other about it. It's already happening. And so if you can find those pockets that exist, that's really what they definitely are there. And if you start poking around, you'll unearth even more apps and more groups that we're parts of.
Mm-hmm. Absolutely.
Any particular social media influencer? Somebody is asking. You utilize all social media influencers. Any that any of you would recommend?
I'd say any of the ROC organizations, the Raising Our Celiac Kids, because no one cares more about addressing symptoms and curing celiac than parents of little kids with celiac. So any of the ROC organizations, that a lot of them have Facebook groups, those would be a great place to start.
Yeah, there's several celiac support groups on Facebook that I'm a member of, and they have lots and lots of members. That would be a great one also.
And to Jennifer's point about the social media influencers, there are celebrities and famous people with celiac disease, and they have millions of followers and people who are tracking their everyday lives, even though, you know, celiac disease might not be their number one advertisement. They might not even, you know, a lot of people might not even know they have celiac disease, but someone like Elizabeth Hasselbeck, right? Like, people just know who she is, even though you don't necessarily know she's someone with celiac disease. So getting in touch with those influencers already would be an easy outlet.
John, do you have any?
Yeah, just maybe a follow-up question.
Okay.
These are all wonderful ideas and I've written them all down, but how about maybe something less technologic? We had the handouts in the office, but I'm just trying to, again, get to a broader, diverse population. And are there any magazines or newsletters that you all tend to subscribe to, that sort of thing?
I just don't think a lot of younger people do newsletters and magazines anymore, to be honest. I think the way that, and I'm old, I'm 54, but I know that a lot of the younger people who I know, who they don't use newspapers, they use social media. I mean, I hate to say that, but that's going to be your best friend.
Well, on that note, I'd have to say you're not old, but thank you all for thank you all for your comments, John. I hope they were helpful.
Thank you so much.
I'd like to invite Kristen to come back to speak.
Hi.
Ask her a question.
Yep. Hi, everyone. Kristen Neff. I work at Nokion. We're a small biotech company developing a treatment right now for celiac disease using immune tolerance. I head up clinical operations, which means that my job is to oversee all of our clinical studies. I've also worked at Imisanti, who I think has been mentioned a few times today, that previously was developing treatments for celiac disease. First, I want to thank all of the patients who participated in clinical trials. This is my world. I live and breathe this every day. And it's really heartening to hear that you all, for the most part, had good experiences. This is wonderful because this is our goal. But you know, you may not know that we never have any contact with the patient. So I think Francisco mentioned that. So all of the information we get is sort of secondhand or third hand. So to hear from you directly is actually very helpful. And to Kelsey specifically, we don't want to hear about experiences like yours where you are very interested in participating in a clinical trial and you just can't seem to get, you know, to the right person to get in the door. So it's good to hear that experience as well, because we work very, very hard to try and make sure that doesn't happen. So my question for all of you is, when you first decided to participate in a clinical study for a celiac disease treatment, what was the biggest surprise, or what did you learn about yourself, your disease, as a part of participating in that study?
I think for me, because I have a more severe form, I learned more about what I can and can't eat, because I can't eat any gluten-free grain as well as gluten grain. And so it kind of taught me how to pay attention to my body so that I was able to figure out what I could and couldn't eat, like what was causing the symptoms to continue to be so bad. So I don't know if that makes sense, you know, along with, when I did this study, I had a little thing to track bowel movements, symptoms, to track, symptoms. And by doing that, I was able to say, oh gosh, look at all these foods that are killing me. And I was able to pinpoint things, and it helped me gain control over my symptoms, my life, what I could and couldn't eat. Became more restrictive, of course, but I feel much better now. So it was worth it.
That's great.
For me, go ahead. I'm sorry.
Okay. Something I really gained from the study I was in was I'm kind of a lab geek, and I really enjoy tracking labs and seeing results. So I ended up having 2 endoscopies, a before and after, with my study. And it was really reassuring to me, because in both cases, you know, my intestines were in terrific condition. It was really nice and reassuring to see that the incredible effort my family has made to be gluten-free is really paying off, and it's working. So I really enjoyed getting that information.
Excellent.
That's what I was going to mention too. And also the genetic factor. I did not realize that until I started my very first drug trial about, because I asked why so many vials of blood were taken from me. And because every time I went. Good
question.
So the genetic aspect of it, I did not know about until the drug trial. So I learned something.
Well,
and then the endoscopy part too.
Yeah. I really appreciate that, because I know when you sign up for a clinical study and you sign the consent form, it very clearly states you may not have any benefit from this study. Of course, we're studying drugs that we don't know yet will work, and that's why we're studying them. So I was very curious to see if there were other sort of peripheral benefits you had, recognizing that the drug is under study. You maybe didn't even get the drug, you maybe got placebo. So
right.
Thank you for that. Do I have more time, Jennifer?
We have about 15 seconds.
Oh, okay. Well, my only other question was going to be, did any of you think at one point about dropping out of the study and then decide to stick with it? No. Oh, well, that's wonderful.
I did, because I had to ingest gluten for one of them, and I thought about it a lot, because I do react severely, but I kind of stuck it out, and I did okay. So,
well, again, on behalf of everybody developing treatments for celiac disease, we thank all of you.
Agree. Thanks, Kristen. And I guess I actually have a question, and I want to pose it to both sides of the panel. And that is about the subject of compliance in a clinical study. And I wanted to ask the patients what they think compliance means, and if they've been compliant or thought about not being compliant. And on the other side, I'd like to ask the panelists why they think compliance is absolutely crucial to a successful study. So I think whoever wants to jump in and talk, it's all yours.
I have to be honest, the one drug that I took that made me feel so great, I had to really be a good person not to stock up on some of that medicine and keep it for me for later if I felt bad, if I had something to take, because we're like desperate people who have no options for any kind of treatment. But of course, I didn't do that, but I thought to myself, my goodness, I would love to stock up on some of this so I can have it when I have a really bad reaction. But I didn't do it. But it is very tempting when you don't have a drug that helps you to have something, to actually help you. And the drug really was fantastic, and I cannot wait until it comes on the market. So
during a study, did anybody forget to take their study medication, or did you just not want to, or do you know anybody that wanted to drop out, or something like, you started and then you didn't want to drop out, so you just stopped you know, being compliant, anything like that you know about?
The only part of compliance that was a challenge for me, it wasn't, I mean, I was taking a drug and gluten every day. That wasn't hard, but the documentation, because I work overnights, I work weird hours. And so I was, you know, I wasn't always in the same place at the same time of day when I was supposed to do the recording. So that made the recording a little bit challenging, but the study site was very accommodating. And if I missed the time window of doing it online, they had paper backup. So I mean, I intended compliance, and they helped me be compliant on that piece.
Anybody from the biopharma side want to share their thoughts on why compliance is crucial?
Yeah, I'll just say something.
Oh, go ahead.
Sorry, I'll start quickly. So I think compliance, so there's two aspects I want to say. So it's really important. So if we know if something doesn't work, it doesn't work because of something with the drug, not because people weren't doing it as, you know, as expected. I think there's two parts of compliance. So one is the sort of the active part, like take the medicine as directed, fill out your surveys as said. But there's also the non-study part of compliance, which is don't change other things. Don't change your diet in the middle of the trial. Don't take a new supplement, a new probiotic in the middle of the trial. There's all these other things that you don't necessarily think of as compliance, but are actually just as important as all those other things that I think sometimes get missed. So sorry, Kristen, I'll keep it short. Go ahead.
Yeah, I was just going to say, you know, there's sort of the big compliance issues like taking your medication. And then there are small compliance like, oh, I'm supposed to come in 15 days from the last visit, but I can't make it that day. Can I come in 14 days? That is not as critical to getting the study done properly as things like taking your medicine. And what you may already know is that if there are major compliance issues with a particular patient, they may need to come out of the analysis of the study because their data wasn't collected the way everybody else's data was collected. And so, you know, from our side, we really want compliant patients because every patient is so important, and we don't want to have to take a patient out of the analysis because you know, we determined that they actually were not taking the medicine.
And if I could just add one thing, just to be honest with the team. So if you do miss doses, just be upfront about it. Don't try to hide it, because no one's going to yell at you. It's just, we just do need all the information to make our informed decision. So
thanks, John, and everybody for offering some comments there. Our last biopharma participant panelist is Beth Ann Reedy, and I'd like to have you introduce yourself and ask your question.
Hi, everyone. I'm Beth Ann Reedy. I work as the Discovery Medicine Lead for GlaxoSmithKline's celiac disease program. And just as Francisco actually had us on one of the earlier slides, Dr. Chetan Khosla, he started Satari, and GSK collaborated with that company and actually now on the license for the compound, so the transglutaminase inhibitor. And we're currently in phase 1 trials for our program and looking forward to moving through the clinical development plan into phase 2, hopefully next year. So as Francisco and I think Patrick had said, you know, all the good questions are taken, and a lot of them that I had written down are, I guess, sort of as follow-up to some of those. How many of you actually, it seems most of you are getting your celiac data and trial participation information from social media. Do any of you look at clinicaltrials.gov? Is that someplace that you would look to participate in a trial?
No, I didn't know about that. I'm going to write that down there.
Yeah, I wasn't aware either. I've looked at that a few times, and I'll just once in a while, if I haven't heard anything new, I'll seek out, you know, I'll go look around the CDF website, or I check the University of Chicago's Celiac Disease Center website. And those are kind of places that I would go looking for stuff. And those have directed me to the Gov site.
Okay. Agreed. I've had the same experience. I wasn't aware of the clinical trials celiac.gov. And then I mostly just find out through emails, and then I'll go searching the CDF site as well.
Yeah, and if you participated in a study, they'll send you an email from that particular study group as well saying, hey, we have a new celiac study if you'd like to participate in it, or you get their general studies anyway via email. I don't know if that's how you're getting emails as well, but that's what I get.
Mm-hmm. Yeah, I always get it through email. I'm not really on social media that much, so I go searching.
Do your physicians that you see bring it up at all, or is it only once you've participated in a trial then that you're on that distribution list?
My general physician did not, but the gastroenterologist I sought out after the drug trial, he does drug trials, so he does because he knows I've participated before. But no, general gastroenterologists generally don't, which is sad. They should.
I will say, because I've moved, I've had a series of 6 different gastroenterologists, and not a single one has ever mentioned any kind of clinical trial at all.
Yeah.
And PCPs don't even generally understand what celiac is. So
no,
that's true.
They don't.
Yeah, I think that's where it's important, as everyone sort of has said about being an advocate within the trial. I think it's also important to be an advocate even just for yourself and looking for diagnosis, which it seems most of you are. And I think most of the celiac patient population has to be that way, advocate for themselves to look for the test. I guess just one other, and I know we've talked, I think it was Patrick who asked this about, how to convince somebody to actually participate, what you gain out of it. What would make you not want to participate in a clinical trial? Now, a lot of, unfortunately, clinical trials are conducted in a certain way where assessments need to be done on certain days, or you need to travel to sites or get specific things. But what would make you not want to participate in a trial?
The timing and the scheduling is probably the only thing that would bar me. In fact, I've registered for another trial that I'm going to start this month and goes into next month. And we had to reschedule it so many times. I came close to backing out, but because it was so specifically timed for the visits, but we were able to make it work. So any flexibility in scheduling, I think would really help make it easier to take part.
And also, I understand that the blood work and whatever work, urine samples or whatever have to be taken at the site, but it would also be like, for instance, I live about 30 minutes away from the site that I was participating in the last one. And so it would have helped if I could have gone to a local lab and have gotten my blood drawn and given my urine sample just on the way home or whatever, instead of having to go to that specific site. That was probably the hardest part for me, was to have to make that appointment to go get the blood sample and the urine sample. And I understand that won't always be acceptable, but it would be nice to be able to just go to a lab that's designated near your house or whatever, just to drop it off.
Okay. You okay, Beth Ann, or did you have any more questions?
I had another follow-up, but I'm not sure if we're out of time or not.
Well, we are, but we've been granted a few more minutes. And what I wanted to do was turn it around and allow, I have some questions that I'm monitoring coming in from the attendees. Plus, I'd like the panel of patients to be able to ask you guys some questions. And if that's okay with you all, biopharma people. And so as I'm a Canadian, I just happened to see a question from a Canadian coming in here wanting to know, is it possible for Canadians to participate in any of the trials going on in the States? And I also saw a question from someone in the UK asking that same question. If any of you could speak to that, cross-border participation.
I can tell you that it's absolutely fine for Canadians to participate in the US. In Europe, it's a bit more difficult. we have sites open in the Netherlands that accept patients from anywhere in Europe, including the UK. And we have paid for UK citizens to travel to those sites in the Netherlands, but that's the only country that accepts cross-border trial participation. The proactive study will start in Canada soon, so that might help there. But yeah, these are great questions, and it just shows how there's no bad question.
Jennifer, this is Pat. Yeah,
Okay.
we do have sites. The lorazepam trial has sites in Canada.
Okay, that's good to know. So it seems like there's a lot of patients out there that wanted to join these trials, which is awesome. Hopefully a lot of this information is helpful for you all. Last few minutes, the patient panelists, would you like to fire a question at the biopharma people? I have a couple more minutes.
One of the questions I would have is, I think it was asked or touched upon earlier, but what I understand the drug trial, the first one that I was in that helped me so much was 7 years ago as well. And so I'm just wondering, what is it that's keeping the drug from being put on the market at this point? Like, what are the barriers? And I understand it takes a long time, but I'm just wondering, like, what is the longest amount of time that it could possibly take to get the drug on the market and get a prescription for it?
So, I think there's many answers to that question, but let me take one. One of the things that makes it challenging and has slowed things down in celiac disease is that there's no approved pathway for approval, right? For some other diseases, you know exactly what you need to do. You know exactly what you need to show at every step of the way because it's been done before. And the FDA agrees, and the European agencies and Health Canada, everyone agrees. In celiac disease, we're sort of in the Wild West a little bit, where there is no blueprint. And because of that, people do trials, and then they get, they have to change the trials and do something over again. And then the FDA says, I want something different. And so you wind up, it becomes much more inefficient than it has to be. And I think that's been a big barrier. Again, I think we're in a much better place than we were 7 years ago. So I don't think we'll see that again. But those were in some ways maybe necessary steps to go through to get to where we are today.
If that ever, can I ask a follow-up question? If that ever does happen, and there does become a blueprint and you see a disease or a medication that was working 7 years ago that all the participants said was amazing, then will you go back to that drug and possibly try again? Because maybe we had the same thing and it helped us both. Does it?
Yeah,
do
I
things
guess
ever get reviewed?
I would ask the question as to, was it really amazing for all the patients in the trial? And it may have been a bit more mixed. If there was that clear a signal, it would have probably found its way forward much more quickly. And if the signal is mixed, it gets harder. But yes, I think that if there is a clear pathway, some of these older therapies might be looked at again to see if they could make it up that clear pathway. But it is a process, and most drugs actually fail rather than succeed. So you need a lot of shots on goal before you get that one score.
And sometimes it could have been a safety issue, when they did further drug studies, whether toxicity or drug-drug interactions, there may be and as John said, it might not have been fabulous for every patient. It might not, could have worked on a specific patient group and not everybody might have had the success on it. And so it would have been not considered as efficacious as it was for each of you or, how your experience was, unfortunately.
I was going to share very quickly that in response to how long it can possibly take. So prevention, we have finally a drug we're going to hopefully get through the market. It's being evaluated by the FDA at this time, and they said they will answer by the end of July. It's a drug for type 1 diabetes to prevent type 1 diabetes so people don't need insulin. So this will be a huge advance because until now, If you have type 1, you need the insulin.
Mm-hmm.
It took over 20 years to develop this drug. So unfortunately, it's a very long process, but I think we can start to see some light at the end of the tunnel in celiac with larasotide, with AMG 714, other drugs that are in late stage of development. So hang in there and do the gluten-free diet.
Well, I think,
For sure.
thanks all of you. I think I'm going to end the session tying all of this back to money. And if there's no money, if we can't advocate for more money from great programs like NIH, then these programs aren't going to move forward. And we have 20, as Francisco said, 25 great programs out there right now. A lot of them are really small, and we need funding from all different places to move things forward. So this is again why we're here, to learn how to advocate to help ourselves as celiac patients. So with that note, I'd like to thank everybody in the session for being honest and willing to answer some tough questions. And I hope you got a lot of information from both sides. I hope the biopharma folks got information from the patients, and I hope all the patients participating learned a lot. So thanks very much, and I appreciate all of your participation.
Thank you very much.
Thanks for inviting.
Thank you to the participants.
My name is Joe Murray. I'm a gastroenterologist at the Mayo Clinic in Minnesota. I'm here today to talk to you about the history and the engagement of the scientific community in celiac disease here in America. I came to America in 1988, not to study celiac disease, but for other interests in GI. However, because I came from Ireland, where celiac disease was both common and well recognized, I got involved in that area. But the 1990s were a scientific desert for celiac disease in the US. There were 2 or 3 centers around the country that were making stalwart efforts to engage with celiac disease. But it was never a disease that got much attention, and nor did it gain much funding. An inkling of interest came after a person with celiac disease visited their congressperson at the Hill, and the congressperson discovered to their chagrin they couldn't provide any hospitality to that patient. Now, those were dark days for celiac disease, when there was very little available, little done, and little known about the disease. In fact, it was largely an orphan disease. But due to this one person's engagement with Congress, they sent down a request to the NIH to study it. And in 1997, I spoke at an interagency committee meeting about celiac disease. At that time, I'd been doing a little bit of research on celiac disease and type 1 diabetics. I presented our data, and there were other presenters. And the result of that meeting 2 years later was a call for funding for celiac disease. And indeed, I was lucky enough to gain funding for studying celiac disease where I now am in Rochester, Minnesota, as well as a couple of other grants that were funded. And this was a very hopeful beginning. Next, there was a consensus conference in 2004 that the NIH sponsored. And this drew in a lot of people from both the US and elsewhere. Anybody with any knowledge of celiac disease. It brought in patient advocacy and patients to the fore, as well as what I call a Supreme Court of scientists. These were scientists and clinicians who were not experts in celiac disease, but they were to stand in judgment and determine, well, what's known about celiac disease, what's appropriate practice, and indeed what needs to be done. And they generated a consensus report in 2004 that really identified the gaps of knowledge and indeed the depth of ignorance almost about celiac disease that pertained at the time. But it was a time of great hope and anticipation. And subsequent to that, there have been a number of groups, not many, that have been funded intermittently over those years since in celiac disease. And some have made major contributions to the science of celiac disease. But that community has not been growing. And perhaps more troubling, there hasn't been a lot or a large cadre of new people who are involved, engaged, enthusiastic scientifically about celiac disease. There are a few standout people, but not enough to replace those of us who've been doing this for a long time. And celiac disease was largely considered a relatively rare digestive disease. All of that changed in 2019. And that changed because of one person's engagement with people in the legislature, in our national legislature, to bring to their awareness that celiac disease had a broader impact. It wasn't just a digestive disease, it was an autoimmune disease. And it belongs in that family of autoimmune diseases, and as such deserves a broader focus. And since 2019, when Marilyn Geller, your fearless leader, presented to a appropriation subcommittee the voice of patients with celiac disease, the need for expanding the science and the engagement of the tremendous research potential present in the US and elsewhere to address the needs of this disease and the people who suffer from it, and also the relevance of this disease to the broader community of people with autoimmunity. And since that time, we've had presentations at the committee that helps advise the NIH on autoimmunity. And now, indeed, the CDF has a seat at that table. So they are now considered a bona fide part of that table of autoimmunity. And now we're excited that through this advocacy, the NIAID, which is the National Institute of Allergy and Infectious Disease, as well as the NIDDK, are jointly organizing a research workshop. And this is an exciting, it'll all, of course, be, because of the times that it'll be, a virtual workshop. They are going to address the key areas of endeavor in research in celiac disease. Some of this is very basic. It's looking at the lining cells of the intestine. It's looking at basic immunology, but it's also looking at new areas of therapy that could be ways of treating the disease beyond or in addition to a gluten-free diet. So much of this will be discussion. It's also bringing people in from other disciplines. It's broadening the reach of celiac disease, or broadening the perspective of celiac disease. And a key part to this is to try and engage our younger investigators, our new investigators, to bring them into celiac disease, to think of it as a disease that is both challenging, engaging, and a terrific example of an autoimmune disease that we can understand a lot about, and also potentially impact the other autoimmune diseases. And we see this as a colloquium of experts. And hopefully to come from that will be a detailed report, indeed a roadmap for what the National Institutes of Health can do. Why does this matter? Why does it matter to the people with celiac disease? Well, people with celiac disease, you've been living with the same treatment for 70 some years with no progress in other things. We have made progress in terms of recognizing different mechanisms that drive this disease. And this workshop will really identify new potential areas that we can address. But it's through this foundational work that needs to be done that we can build on new ways to detect, diagnose, manage, and treat patients with celiac disease, and ultimately even dream of curing it or preventing it in the first place. And those of you who are familiar with work that I and others have done, celiac disease went from a very rare disease 70 years ago to one that is quite common and may affect, in some circumstance, over 1% of the population. So it's a disease that's worthy not only of our attention, but worthy of the research community's attention and our tax dollars at work. And finally, celiac disease has to compete. It has to compete with the diseases that have already had an established research community. We need light to grow. The little tree of celiac disease research needs a bit of space, and it needs light and fertilization to grow and to be able to compete on the same level as every other disease for the attention of our tax dollars. Thank you for your time.
Good afternoon, everyone. I am Ritu Verma. I'm a professor of pediatrics and the medical director of the University of Chicago Celiac Disease Center. I've been involved in the celiac disease world more in the clinical space for almost 20 years. And initially it was at the Children's Hospital in Philadelphia as the founder of the Celiac Disease Center there, and now here in Chicago as the medical director of the University of Chicago Celiac Disease Center. I'm also the SSCD liaison for advocacy with the CDF. So the SSCD is a society that's for the study of celiac disease. I'm sure all of you or most of you have heard of different societies for different diseases. And this happens to be the society that is for the study of celiac disease. And as you can see on the slide, that the mission is to really advance the fields of celiac disease and gluten-related disorders by actually fostering research and promoting excellence in clinical care. And this is really the mission of the SSCD, and the membership is made up of physicians, dietitians, researchers, trainees, and an excellent organization to become a member of. And I am their liaison for advocacy with the CDF. And everyone knows about the Celiac Disease Foundation. So just to tell you a little bit about myself, I have been a clinician in the United States for 30 years. And initially, my mission really was to take care of patients and the patient's well-being. And I've watched the patients with celiac disease go through the struggles, the trials and tribulations of having to live in this world, which is filled with gluten. And at that time, my only sort of advocacy for the patients was working with them, till I actually attended the NIH conference, the Consensus Conference in 2004. And that's where I met other advocacy groups and learned that there was another way to really help my patients become an advocate. And since then, I have found so much pleasure in working with foundations like the CDF and learning from them, learning from Marilyn, how to become an advocate. As a physician, I know how to manage the clinical care of the patients, but not so much how to advocate for them on a national level. And this has been very, very rewarding for me. So today, the first thing that I am going to talk about and bring to your attention is the Gluten in Medicine Act of 2019. So currently, the drug manufacturers are not required to label the presence of gluten in prescription medications. Can you just imagine that if the anxiety that patients would have if they did not know that the medicine that they're taking has gluten or no gluten? As all of you will know, that if you are a patient with celiac disease, you've been educated, you've been taught, you've learned, it's been ingrained in your brain that you cannot put anything in your mouth that has gluten in it. Think about a parent who has a child with fever. And this happened to me several years ago. One of my patients, her child had a fever. She went to the emergency room, was prescribed an antibiotic. She went to the pharmacy to pick up the antibiotic, her child in a lot of pain, discomfort, and fever. Unfortunately, no one could tell her if that antibiotic was gluten-free or not. Did it have gluten or not? So just imagine the stress and anxiety that a parent is going through, where the medication is in their hand, but they're not comfortable giving it because it does not say on it, and no one can tell them, is there gluten or not in there? So this Gluten in Medicine Disclosure Act will make it so much easier. The stress, the anxiety would go away. It would make it safe for the families to really be able to go to a pharmacy and pick up a medication. 3 million Americans are living with celiac disease. 3 million Americans worry each day if they have to take a prescription medication. Wouldn't it be nice if we could all have this Medicine Act of 2019 be passed? Would make life so much easier for all of us. So my next point of discussion is the Medical Nutrition Therapy Act of 2020. So all of us who have celiac disease know that currently the only treatment for celiac disease is the gluten-free diet. Unfortunately, at this time, the medical benefits do not cover the cost of the visits to the nutrition expert, who really is prescribing the medication. So we cannot write a prescription and say, go see a dietitian and that it would be covered. However, for other diseases like Crohn's disease, multiple sclerosis, we can write a prescription for the medications. So at this time, we know that Medicare only covers outpatient medical nutrition therapy for patients with diabetes or kidney disease, and so leaves many, many seniors without care for celiac disease. The Medical Nutrition Therapy Act of 2020 would give Medicare beneficiaries access to the care that they need to provide coverage for people with celiac disease. Wouldn't that be wonderful to have that anyone, a nurse practitioner, a physician assistant, clinical nurse specialist, psychologist, could refer their patients so that they would be able to see a registered dietitian or a nutritional professional who is really the expert to manage the gluten-free diet. We do know that the dietitian is really making an impact in the management of celiac disease. Besides teaching all of us about the gluten-free diet and managing the diet and managing the patient when they're being diagnosed, they're also very important for follow-up. So we do know that celiac disease affects the intestines. It causes malabsorption. So you're not able to absorb all the nutrition and the vitamins, and the dietitian would help the patients lead more healthy lives by giving us the information and the treatment. So you would say, okay, I've been diagnosed with celiac disease. I've seen a dietitian. I don't need to see a dietitian again. That's not true. Part of the reason is that the gluten-free diet itself is deficient in many vitamins and minerals. So who is the expert who's going to teach us so that we prevent other diseases from happening? Is the dietitian or the nutrition expert. We also know that obesity is a big, big problem in the country. And unfortunately, as children and adults start on a gluten-free diet for celiac disease, some of them do end up with obesity and other comorbid conditions. If we could see the dietitians on time, we would prevent some of the comorbid conditions. So where does the dietitian make an impact? Monitoring growth, especially in pediatrics, and advising accordingly, educating the families. You know, it's not so easy to go on a gluten-free diet. Yes, you could take away wheat, rye, and barley, but it's more than that. We've got to read the labels. We have to worry about cross-contamination, because any of those things would lead us to have other diseases in the future. The more knowledgeable the patient, the more compliant they are. The more compliant, the less the anxiety and less other conditions happening in the future. We do know that if you're not on a gluten-free diet or not on a healthy gluten-free diet, you could end up with many deficiencies like calcium, could end up with more fractures. There's effect of vitamin B12 and folate deficiency, which can link to depression and anxiety, affects growth, affects a lot of neurological deficits. So in short, a dietitian is the person that we need to treat our disease. We do know that Medicare leads the path to help provide coverage for all. And we also know that Medicaid and private insurances will follow the Medicare guidelines. So it would be really important to get the Medical Nutrition Therapy Act of 2020 forwarded. As I'm also told that both the acts that I've talked about, from the gluten in medication and the nutrition, is going to come forward again this spring, 2021, for further consideration. Finally, I'd just like to leave you some information about the contact for the Society for the Study of Celiac Disease and what the membership benefits are. It involves not just getting the news, but also education and networking for a lot of people. I would like to thank the SSCD and thank the Celiac Disease Foundation to allow me this opportunity to become an advocate and really fulfill some of the things that I miss when I'm just doing clinical practice. Thank you.
Hi Hi, everyone. I'm Vanessa Weisbrod, the director of the Boston Children's Hospital Celiac Disease Program. And I want to start by saying thank you to the Celiac Disease Foundation for inviting me here today to talk to you all about advocating for celiac disease accommodations in learning environments. This has been an amazing project that we've worked on with the foundation, both our team in Boston as well as my former team at Children's National Hospital in DC. And we're really excited to tell you all about what we've developed today. So to give a little bit of background, we know that celiac disease affects about 1% of children in the United States, most of whom attend federal and state-supported learning programs every day of the week. These are public schools and also many private schools that also receive federal funding. We also know that celiac disease can have significant effects on kids and their families, but also on the schools that they attend. There are lots of places that kids can come into contact with gluten at school. But first, we know that lots of kids and teens don't always follow a strict gluten-free diet, and most often these transgressions happen when they're eating meals with their peers. Often this happens lots at school, whether it's snack time, in the cafeteria, at celebrations. There's lots of times when food can come into play. Like I said, lunchtime, class celebrations, cross contact with gluten-containing materials, especially in early childhood, things like Play-Doh, paper mache, art supplies, science experiments, and cooking classes, or as many schools call it now, family and consumer science classes, when the materials they use contain gluten. We know that sometimes kids with celiac are excluded from these learning activities because they need accommodation. And we also know that kids who feel less integrated into school activities are less likely to succeed on the gluten-free diet. And we all know that not adhering to the gluten-free diet can lead to negative short and long-term health consequences. There are also lots of social and emotional considerations for kids with celiac disease. Sometimes kids attract negative attention from their peers when they eat different types of foods, when they have to ask lots of questions in the cafeteria, or when they're having symptoms of a gluten exposure. On the flip side, we know lots of people with celiac disease are asymptomatic, and when they don't have a visible symptom, they can be judged by peers who think that their celiac disease diagnosis isn't real. Students often experience teasing, taunting, harassment, and bullying by their friends, by teachers, coaches, and sometimes the parents of their friends. But the good news is that we believe we can prevent all of these things from happening by simply having appropriate accommodations. So there are lots of federal laws and regulations that govern celiac disease. I'm going to start by talking about those that govern a disability. So the Americans with Disabilities Act of 1990 defines a disability as a physical or mental impairment that substantially limits one or more major life activities. As we all know, with celiac disease, eating, digestion are major bodily functions that are impacted, and so celiac disease is covered. There's also Section 504 of the Rehabilitation Act of 1973, and this prohibits discrimination from all institutions who receive federal financial assistance, including schools, and this would be public schools or any private school that also receives federal funding based on having celiac disease or any disability. And what this law requires is that these institutions design programming that adequately meets the needs of students with celiac disease in the same way they meet the needs of other students. But what's important to note is that the accommodations have to be reasonable. So they have to be things that don't dramatically change the structure of the institution, but they must accommodate the celiac disease diagnosis. Then there are laws that govern food. So we have the National School Lunch Act, which makes gluten-free meals for students with celiac disease. So any student who would receive a free or reduced cost breakfast or lunch would also be eligible to receive a gluten-free meal. The Child Nutrition Act strengthened and expanded the National School Lunch Act by giving new equipment and services to schools to expand the food options that they could give to kids. It also, very importantly, allowed the USDA to set uniform standards for nutrition at school. So what this means, and is so helpful for kids with celiac disease, is that the meals served to all students the meal for kids with celiac disease has to meet those same nutritional standards. So for example, a hot meal for a hot meal, or a meal that has the same nutritional and caloric value of food served to other students. So we wouldn't see dry lettuce as an equivalent for a grilled chicken sandwich. And finally, of course, the FDA's gluten-free food labeling law, which regulates the term gluten-free. So anytime a packaged food would be served to a student in a school, that it must, at a minimum, meet the criteria of the FDA's gluten-free food law. So now, how do we create a way that's standardized to apply all of these laws in schools? So we are so grateful to all of these wonderful individuals who came together to help us do this. We had quite an amazing group. We had providers from 10 pediatric hospitals, 14 education associations, patient and physician advocacy groups, teachers and administrators from public and private schools, parents of kids with celiac disease, students with celiac disease, a lawyer who had just the most incredible expertise in education law, and a gluten-free food manufacturer who helped us do this. And what we came out of these meetings that we held were the 2020 voluntary recommendations for managing celiac disease in learning environments. This document is a set of recommendations that can be applicable in many different types of institutions. So as I've mentioned, public schools, private schools, charter schools, daycare centers and in-home daycares, and institutions that do and do not receive federal funding. The final recommendations were also aligned with the format and detail found in other guidelines, like those for diabetes, food allergy, and asthma. And the reason for this is that we wanted to make sure that when people looked at these recommendations in schools, that they were familiar, that they weren't totally reinventing the wheel. So we developed these to be applicable to any 504 plan that a student would have. So now we are at the phase where we are teaching people how to do this and providing information so that your family and your schools can take advantage of all of this wonderful work. So in partnership with the Celiac Disease Foundation, we've launched the website school.celiac.org, where there is a series of 3 training programs, one for educators and caregivers, one for food service providers in learning environments, and one for parents and guardians of children with celiac disease. This is an entirely free program that is open to everyone to come and to learn about the laws, to learn about creating 504 plans and how you can help support a child in school. So as I mentioned, the program has 3 different entry points. The first is for educators and caretakers. So this would be applicable to people in schools like administrators, teachers, nurses, psychologists and counselors, custodial and cleaning services, transportation, and child care center staff. For food service providers, this would be applicable to food service dietitians, food service managers, the staff that works in the cafeterias, as well as parent lunchtime volunteers. And finally, the program for parents and guardians of children with celiac disease. This module has so much heart in it, where so many parents came together to share their experiences and their kids too. So if you're out there watching, I would definitely recommend taking a look at that. So as you're going through the program, you're going to see lots of great things. Each track has a series of video lessons as well as post-test questions to make sure you've learned the information found in that course. There are videos that have information, case studies, and role play, and each course takes approximately 1 hour to complete, so it's not a huge time commitment. And of course, it's free of charge, so we're trying to make it as widely available as possible. And at the end of the program, you get a certificate of training showing that you have completed the course. On the flip side of things, we know that it's really important for medical providers to understand all of these things. So we've also worked with Open Pediatrics to build a continuing education program for medical providers. There is a CE program for physicians, nurses, social workers, and psychologists. We want to make sure that the information is disseminated at the point of diagnosis so that when a child finds out that they have celiac disease, the care provider is immediately letting them know about these great resources to help them get set up for accommodations of school. And again, as we've heard from many providers, that even though this course is specific to celiac disease, the laws and the lessons that they learn are applicable to many other conditions that they treat beyond celiac. So we've been hard at work disseminating this information, and since we created the recommendations, so far we have used them to set up plans in 33 states that we know about. And we're hoping by the Advocacy Summit next year that the entire map of the US will be colored in, that there are states everywhere using them. So how can you help after today? First of all, read the recommendations and complete this incredible training program. Send the information to your child's school nurse, guidance counselor, psychologist, food service provider, and classroom teacher, so we help them get the right education too. Make sure that your own child has a 504 plan set up at school. Host a meeting for your parent-teacher association to talk about how they can support kids with celiac disease, and use all of the materials found in the training program. Tell your child's pediatrician and gastroenterologist about the continuing education program on Open Pediatrics. This is a great opportunity for them to learn about supporting kids with celiac disease while also getting CE credits. And if there are any medical providers watching right now, take the Open Pediatrics course. It's a great way to learn about supporting your kids with celiac disease at school. So thank you again to the Celiac Disease Foundation for having me here today, and I'm happy to take any questions that you might have.
Well, thank you to Dr. Verma and to Vanessa for those excellent presentations. I know a number of you are very anxious about the number of polls that we have today. This is poll number 3. There will be a 4th one after our last session of the day, which is coming next. If for some reason you have not been able to complete all of the polls, but you would still like to be a state advocacy ambassador, we ask that you email Sierra Manning, and she will put her email address in the chat for you. So while you are contemplating the poll, I am going to answer one question that was directed at Dr. Murray's talk. And the question was, for the West Coast, why are there no hospitals or medical systems or celiac disease programs to the extent that there are on the East Coast? Now, I do want to say we do have a program at Stanford and we do have a program at UCLA, but yes, they are not as well known as their counterparts back east. And as Dr. Murray said, there needs to be research money, federal research dollars, NIH research funding to attract young researchers into the field. So what we will be talking about in our next session is what you can do as advocacy ambassadors to help assure that we will have this NIH funding that will attract researchers into the field, and then we can see celiac programs across the country. So Dr. Verma, would you like to add to that?
I'm sorry, Marilyn, I didn't get the question.
The question is, what do we need to do to develop more celiac disease programs and centers across the country? So besides the NIH funding, since you now are the new executive director of the UU Chicago Celiac Disease Center, what are your thoughts on that?
I think, money always counts. Money speaks. Probably to have really good centers, we need to educate our younger physicians to get into research with celiac disease. So what is a center? A center is made up of clinicians, researchers, dietitians, psychologists, social workers. That's what a celiac center is all made up of. So if you need to have a physician to lead the center, you need someone who's committed to celiac disease and who really has a passion for it. So from a clinical standpoint, making it exciting for the GI fellows to be excited about working in celiac disease. And medications, when they come into a disease process, always is exciting for the young folks. And then getting a lot of younger people excited and interested, and the infrastructure in hospitals, academic centers, the administrators need to find value in patients with celiac disease. And that's where the advocacy groups come in. So I think it's a lot of things that go in to build a center, but the most important thing is to have someone who's passionate about the disease and then works with the administrators to support that.
So I do want to add that, yes, California-centric here. I forgot that we have an excellent program in Seattle, Washington. My apologies to the state of Washington, run by Dr. Dale Lee. So Vanessa, we have a couple of questions about the 504 plan. And one of the questions is, since independent schools are exempt from 504 because they do not take public funds, is there a way to get them interested in our school training program?
Absolutely. And we definitely develop the recommendations to first and foremost meet the requirements of the 504 plan, but to be useful to any institution that would manage a child with celiac disease. So before you absolutely write off the 504 plan, I would first verify that your child's school doesn't receive any sort of federal funding. There are many private schools that do accept federal grants. And so I would verify that before you forego asking for the 504 plan. Mary Vargas, who is the attorney who worked with us on this, gave us a wonderful site to check this information. And I'll put that in the chat so people can use that as a resource to double check. If your school definitely does not qualify for a 504 plan, I would still recommend sending them the materials. Just by reading through these materials, they're going to get a lot of really good ideas for how to help your child succeed at school. And many private schools are willing to go the distance to make sure that your child has a good experience.
So second to that, the question is, if my student, my child, is managing their celiac disease well at school, do I still need a 504 plan for them?
Absolutely. And it's for the things that you can't think of right now that we want to have that 504 plan in place. One of my favorite examples of this is when we had students in Washington, D.C. who were affiliated with Children's National, who were going on an outdoor education trip. And the site that they were going to did not want to accommodate the gluten-free diet. They said, we can't do it and we're just not going to. And so the students who had 504 plans went back to their school and said, well, what are we supposed to do? So they met with the site. The site said, well, you could send frozen food in for 4 days of being away. And the parents said, well, we don't want our kids having frozen food that's defrosted. They did not have a microwave, by the way, to warm the food up. And so it was a very discouraging situation where the families were worried about their kids eating at this school affiliated trip. And so thankfully, these students had a 504 plan in place. And our community education specialist, Joanna McMahon in DC, was able to go to the Department of Justice and help get a ruling that the school really did have to provide meals for these students with celiac disease. And what ended up happening was the school district's home cafeteria had to bring the food every day for these kids to eat hot meals during the trip. And so had those students not had a 504 plan in place, they would not have been able to have the same protections as they did. So this is just one example that the parents may not have thought about beforehand, but the 504 plan came into very good use to help their child.
Thank you.
And if I could just add one thing to that, I think what we as parents have to realize is there's no downside. There's no downside to getting that 504 in place. And to get an emergency 504 is so much more stressful than to actually have a 504. There's really no stigma that's attached to that. I think sometimes I hear that from patients like, oh, my child will be labeled as that. There is really no stigma. So if there's no downside to it, why not apply for it?
So then we have another question regarding both the Gluten in Medicine Disclosure Act and the Medical Nutrition Therapy Act. And the congressional representatives that you met today all support the Gluten in Medicine Disclosure Act, and that is supposed to be launched in April of this year with a big ramp up for May Celiac Awareness Month. So for those of you who participated in the campaign in 2019 and 2020, thank you, and we'll do it again. On our website, we have software, and there'll be a letter that's pre-programmed in that when you put your zip code in, it will automatically select your congressional representatives. And that would be your House representatives and your senators. You can personalize the letter, and with the click of the button, it will automatically email them. And last year, we sent 28,000 emails to Congress regarding this. So when you hear Pat Mayette say today that, Congress is listening, Congress is noticing, it's because of this effort by our community. So as soon as that bill is launched, we will be sending out emails, we will be posting on social media, and we'll be alerting you. And then what you need to do is to not only go in and complete that email yourself, but to put that out to everyone you know, so we can get, again, thousands and thousands of emails to support it. The Medical Nutrition Therapy Act is actually supposed to be reintroduced at the end of this month. And so we'll do the same thing. Please look for our emails, look for our postings in social media, our website. But again, there'll be an email template in the software. You'll put your zip code in, you can personalize it, click the button, and it will go to the right people. And that is the easiest thing you can do for those of you who are asking, what can I do? What you can do is send those emails because Congress does listen. So at this point, I don't see any other questions regarding this session. So I want to just let you know, thank you for making it through today. There were 3 polls so far. I know some people were not able to complete them all. I'll say it again. If you want to be a state advocacy ambassador and you have not completed the 4 polls, please email Sierra Manning. It's in the chat box. The address, email URL for the school training program is also in the chat box. We will be following up with communications after this summit for all of you who registered, summarizing the questions that have been answered with the responses from the panelists and the information that you've heard today. So do not worry if it's flown by. But our next session is our big advocacy training session. So if you do want to be a state advocacy ambassador, this is the one you need to attend.
Good afternoon. My name is Dwayne Musser, and I live in Arlington, Virginia, and I was diagnosed with celiac disease in 2008. I also have a daughter who was diagnosed with celiac at age 5.
My name is Mark Jarjour, and my eldest son, who is 14 years old, was diagnosed with celiac disease a year ago.
Hello, my name is Kelsey Smith, and I was diagnosed with celiac disease in 2016.
Hi, I'm Josh Denny, and I live and work in the Washington, D.C. area. I have a teenage son who was diagnosed with celiac 3 years ago, and I started volunteering with the Celiac Disease Foundation about 1.5 years ago.
I welcome the opportunity to become a patient advocate at the first Patient Education and Advocacy Summit held by the Celiac Disease Foundation in 2020. This was a very rewarding experience as it gave me the opportunity to tell the story of my family's struggles with celiac to members of Congress and congressional staff. I was able to relate how the various public policy priorities that the Celiac Disease Foundation is pursuing in Congress and with the National Institutes of Health are needed to help improve the lives of people with celiac.
I got extremely interested in what the community was doing to find a treatment. I was incredibly pleased when I discovered the passion and all the great initiatives that the Celiac Disease Foundation is doing, including the patient registry, the collaboration with physicians, the patient recruitment, and several others. So I immediately decided to be an active participant with the foundation.
So when I realized that there were ways I could get involved through CDF, I jumped in 2 feet. I participated in the 2019 Advocacy Day here in Washington, D.C., where I was able to share my personal story about the impact of living with celiac disease with U.S. congressional staff. I was also able to participate in a day of training. So I learned more about CDF, about the different trials that were going on, and about how to better lobby and connect with local legislators. And I helped train other folks who were going through the same experience as I was. Since then, I've remained in contact with my local representatives and senators about who I am and what I expect to see from them when it comes to their time in Congress, especially their support of funding for celiac disease research.
Besides being a member of the steering committee for today's summit, I've primarily been working on getting a celiac disease caucus started in the United States Congress. Congressional caucus is an opportunity for members of the House and the Senate to come together around a common interest or concern.
The extensive information obtained at the summit has enabled me to be a better advocate for myself and others with celiac in many ways throughout the year. While I have learned a lot about celiac since I was first diagnosed 13 years ago, I'm amazed by how much we still do not know about the disease.
Celiac disease advocacy is an especially important step in raising awareness that celiac is not a fad diet, but a serious medical condition with life-changing impact for both patients and caregivers.
I know that our government has vast resources. We give it to them every single day via our taxes. And it is very easy for things to get lost in the shuffle of running a government. There are a lot of different focuses that the US government has. And if you are not constantly reminding them of what is important and what the priorities are, it's easy to get lost in the shuffle.
And you can help with this effort going forward from today by contacting your members of Congress in your state and asking them to join the Celiac Caucus.
As a government relations professional who has worked in policymaking for many years, I can tell you that democracy really is a participatory sport. We need more patient advocates so our collective voice is heard loud and clear in Washington, D.C.
I personally know how confusing and intimidating advocacy can be, especially when it comes to contacting a US representative or a senator. But I encourage you to set a small goal and find a friend. You don't have to go at this alone, and having a partner can provide you with confidence and show that what you are doing is part of a group effort. It's important to remember that you're not having to say anything special or incredible or different. You just have to share your own story.
I encourage all of you to leverage your skills and resources, whatever they may be, and be an active participant in this journey. Every action, every phone call, every dollar invested will bring us one step closer to finding a treatment and completely changing the life of the patients suffering from celiac.
Hello, I'm Julia Macbeth, Director of Research and Advocacy for the Celiac Disease Foundation. Thank you for joining us today for the State Advocacy Ambassador Training. Celiac Disease Foundation advocates are the engine behind all that we do, pushing forward policy change that now has our federal government recognizing the seriousness of celiac disease and moving towards funding research to accelerate new treatments and one day a cure. The great thing is that you don't need to be an expert in government or policy to be an advocate. All you need is your voice, your passion, and a commitment to making a difference, and we'll provide you with the resources and opportunities to make celiac disease the national priority it should be. Like some of the sessions before, there will be a short poll at the conclusion of this presentation that you must complete to earn your State Advocacy Ambassador certificate. After the poll, we'll conclude today with a Q&A session, so please enter your questions and comments in the chat box. If your question is not answered, please know that we will be posting to celiac.org a summary of questions and responses in the next few weeks. Let's start with a brief overview of what being a State Advocacy Ambassador for the Celiac Disease Foundation entails. The word advocacy means public support for or recommendation of a particular cause or policy. As a constituent, you are an indispensable part of our democratic system, and your voice has the power to influence Congress and its actions. The Celiac Disease Foundation advocates for policies on behalf of all celiac patients by working with the U.S. Congress, federal agencies such as the National Institutes of Health and the Food and Drug Administration, and state governments. Celiac Disease Foundation state advocacy ambassadors push forward policy change by educating their elected officials about the impact of celiac disease on Americans and why diagnosis, treatments, and a cure need to be a national priority. State advocacy ambassadors include patients, caregivers, supporters, researchers, and healthcare providers. No previous experience advocating to members of Congress is necessary to be a state advocacy ambassador. Everything you need to know to become an effective advocate will be included in this training. So why should you become a state advocacy ambassador? Well, the federal government is the largest provider of medical research funding, but up until recently, federal funding for celiac disease has been limited. Following CEO Marilyn G. Geller's testimony before the House Appropriations Subcommittee in April of 2019, Congress directed the NIH for fiscal year 2020 to devote sufficient focused research to the study of celiac disease. Congress renewed this language for fiscal year 2021. This request of the NIH will need to occur every year. In collaboration with our Advocacy Council from Baker Donelson, new language for fiscal year 2022 has been submitted. The U.S. Congress and federal agencies are making decisions that impact patients with celiac disease that can affect your access to medical care, as well as national funding for medical research. The best way to ensure that your needs are being considered in policy decisions is by sharing your story and explaining how specific policies will affect you or your loved ones. The Celiac Disease Foundation's 2021 advocacy priorities outline our future goals for the celiac community, as well as our current asks of Congress. These include medical research goals to increase funding for the National Institutes of Health for the study of celiac disease, include celiac disease in the Department of Defense's congressionally directed medical research programs, and to include celiac disease in the CDC's Diseases and Conditions A to Z Index. Our advocacy priorities also include important access to care initiatives, including to protect chronic disease patients from discrimination and bolster patient protections. extend Medicare and Medicaid coverage for medical nutrition therapy to beneficiaries with celiac disease, require disclosure of gluten in medications, and to increase FDA funding for necessary enforcement of the gluten-free labeling rule. In the email that was sent to you on Tuesday, there's a link to some of the documents we'll be discussing today. For those of you who didn't have a chance to download the documents or recently registered, we'll post this link in the chat right now. Members of Congress meet with a number of constituents daily, which can sometimes make it difficult for one person or cause to stand out in their memory. This is part of what makes leave-behinds so important. Leave-behinds are documents you give to the member of Congress or their staff member that provide important background information and statistics about the issue you're asking them to take action on. Leave-behinds are a great way to provide a lasting resource that the member of Congress can reference to be reminded of the key points of your meeting. Celiac Disease Foundation leave-behinds may be emailed or printed and can be found at iadvocate.celiac.org. These leave-behinds include a double-sided document that contains celiac disease facts and figures on one side and information about the foundation on the other that may be given to both senators and House representatives. Leave-behinds may also include separate documents for senators and House representatives for any current legislation that needs our community support. As Dr. Verma mentioned in her talk, the Gluten in Medicine Disclosure Act of 2019 and the Medical Nutrition Therapy Act of 2020 were two such pieces of legislation. When reintroduced to Congress this spring, you'll find leave-behinds for each. Here are the leave-behinds on celiac disease and the Celiac Disease Foundation that you can download and email or print when meeting with your senators or House representatives. The About the Foundation page explains our current asks of Congress. For fiscal year 2021, we're focusing on securing NIH research funding for celiac disease and including celiac disease in the congressionally directed medical research programs. In fiscal year 2020, we also asked congressional representatives to co-sponsor the Gluten in Medicine Act of 2019 and the Medical Nutrition Therapy Act of 2020. When these are reintroduced this spring, we'll update the About the Foundation leave-behind to include these asks. As a state advocacy ambassador, you'll receive a login and password to iadvocate.celiac.org to download these leave-behinds. These are the leave-behinds for the Gluten in Medicine Disclosure Act, introduced by Congressmen Tim Ryan and Tom Cole in 2019. There was one leave-behind, H.R. 2074, that advocates gave to House representatives for the House version of this act, and another, S. 3021, that advocates gave to senators for the Senate version of this act. Celiac Disease Foundation constituents sent 28,000 emails to their senators and House representatives in support of this bill, gathering 53 co-sponsors. Co-sponsors are senators or House representatives who add their name to a bill, indicating their support. While the bill was not enacted into law, there are plans to reintroduce it in May in conjunction with Celiac Disease Awareness Month. Once this legislation is reintroduced, similar leave-behinds for this act will be available to you at iadvocate.celiac.org. While all of the advocacy priorities mentioned previously are important to celiac disease patients, we ask that you keep your upcoming congressional meetings focused on the two asks we're currently working on for 2021 in order to make the greatest impact. The first of these asks is that Congress increase funding for the National Institutes of Health for the study of celiac disease. Better treatments and a cure for celiac disease can only be discovered through research. Most research is federally funded. However, celiac disease has been historically lacking in federal funding. The Celiac Disease Foundation has worked to secure fiscal year 2020 and 2021 appropriations report language, directing the NIH to devote sufficient, focused research to the study of celiac disease. Fiscal year 2022 appropriations report language has been submitted, and now it's time to gather congressional support to assure it is included in the fiscal year 2022 budget. For fiscal year 2020, NIH focused the May 2020 Autoimmune Diseases Coordinating Committee meeting on celiac disease. CEO Marilyn Geller spoke on what patients want and need based upon data from our iCure Celiac patient registry and your stories. Doctors Murray, Jabri, and Kelly presented on what research is needed to determine why people develop celiac disease, why there needs to be a treatment alternative to the gluten-free diet, and how solving celiac disease can lead to discoveries in many other autoimmune diseases. In December 2020, NIH invited the Celiac Disease Foundation to be a member of the ADCC, representing all patients with autoimmune disease. Based upon the testimony provided to the ADCC, for fiscal year 2022, NIH is hosting the Accelerating Research in Celiac Disease workshop on March 18th through 19th. This meeting will be open to the general public and will send you registration information as soon as it's available. CEO Marilyn Geller will be speaking on patient needs, so we will also be asking you to share your stories with us of why research funding is important to you. The goal of this workshop is to determine exactly what research needs to be done so that a Notice of Special Interest in Celiac Disease, dedicated funding for celiac disease research, may be issued by the NIH. While these are landmark achievements for the celiac disease community, this request for celiac disease research funding and recognition will need to be renewed on a yearly basis, making your emails to and meetings with your congressional representatives more imperative now than ever. Our second ask for 2021 is to include celiac disease in the congressionally directed medical research programs, more commonly known as the CDMRP. The CDMRP allows Congress to appropriate funds for research that will lead to cures or improvements in patient care for service members, their families, and the American public. These funds are separate from those provided by the NIH. Demographics support the estimate that thousands of active Guard and Reserve service members are currently suffering from celiac disease or are in danger of developing the disease, making them eligible for service-connected disability and ineligible to continue to serve. TRICARE is government-funded insurance for service members, veterans, and their families. Based upon TRICARE covered lives, it's estimated that an additional 77,000 retirees and family members may also suffer from celiac disease. CDMRP funds provide another opportunity for research to benefit those suffering from celiac disease by generating strategies to prevent the disease, and for service members, providing critical guidance on mitigation efforts affecting readiness to allow our service members to continue to serve. The Celiac Disease Foundation, in collaboration with our Advocacy Council, Baker Donaldson, has submitted a fiscal year 2022 request to include $12 million of CDMRP funds for celiac disease research. Like for NIH funding, we ask that you encourage your congressional representatives to support this. Two of our 2020 policy priorities are awaiting reintroduction in Congress for 2021. The Gluten in Medicine Disclosure Act is a bipartisan bill that will require drug manufacturers to label medications intended for human use with a list of ingredients, their source, and whether gluten is present. This bill is planned for reintroduction to Congress in April or May of 2021. The Medical Nutrition Therapy Act is a bipartisan bill that would provide coverage of dietitian visits for Medicare beneficiaries with celiac disease or other conditions. This bill is planned for reintroduction to Congress in late March of 2021. When introduced, we'll prepare new leave-behinds and ask you to engage your networks in email campaigns to Congress and to set up meetings with your senators and House representatives in your home state to gather co-sponsor support. Your personal experience with celiac disease is the most powerful advocacy tool you have. Your story gives you a unique perspective on the hardships celiac disease patients face, and it creates an emotional connection to the issue for legislators. In the email sent to you, we provided a link to crafting your story to affect change. You'll also find this in the Advocacy Toolkit at iadvocate.celiac.org. Use the tips, prompts, and example of an effective story in this document to help you effectively share your story, and remember to relate your story back to our asks for 2021. Here's an example of what an effective story might look like. As a celiac disease patient, the travesty is that the only treatment for my disease, the gluten-free diet, is inadequate and leaves millions of Americans suffering needlessly. I live in constant fear, knowing that ingesting just one tiny crumb of gluten will trigger debilitating illness and increase my risk of cancer, heart disease, and additional autoimmune disorders. Please support NIH funding for celiac disease research for fiscal year 2022 in order to develop new treatments, find a cure, and help improve the lives of patients like me. In the Advocacy Toolkit at iadvocate.celiac.org, you will find resources including how to set up meetings with your legislators, where you'll find information about your legislators, review our sample script for requesting a meeting, and make the most out of your interactions with members of Congress. You can meet with your members of Congress by calling, emailing, setting up an appointment at one of their district offices, or attending a town hall meeting or other public event. During the COVID-19 pandemic, members of Congress and their staff may also be offering virtual meetings. If your congressional meeting ends up being with a staff member rather than the member of Congress themselves, continue to treat the meeting with the same level of importance you would give to a member of Congress. Staff are often the people members of Congress turn to for advice, making them extremely important in guiding policy decisions. When advocating to members of Congress, hello, I'm Julie. Our second ask for celiac disease research. Like for NIH funding, we ask that you encourage your congressional representatives to support this. Two of our 2020 policy priorities are awaiting reintroduction in Congress for 2021. The Gluten in Medicine Disclosure Act is a bipartisan bill that will require drug manufacturers to label medications intended for human use with a list of ingredients, their source, and whether gluten is present. This bill is planned for reintroduction to Congress in April or May of 2021. The Medical Nutrition Therapy Act is a bipartisan bill that would provide coverage of dietitian visits for Medicare beneficiaries with celiac disease or other conditions. This bill is planned for reintroduction to Congress in late March of 2021. When introduced, we'll prepare new leave-behinds and ask you to engage your networks in email campaigns to Congress and to set up meetings with your senators and House representatives in your home state to gather co-sponsor support. Your personal experience with celiac disease is the most powerful advocacy tool you have. Your story gives you a unique perspective on the hardships celiac disease patients face, and it creates an emotional connection to the issue for legislators. In the email sent to you, we provided a link to crafting your story to affect change. You'll also find this in the Advocacy Toolkit at iadvocate.celiac.org. Use the tips, prompts, and example of an effective story in this document to help you effectively share your story, and remember to relate your story back to our asks for 2021. Here's an example of what an effective story might look like. As a celiac disease patient, the travesty is that the only treatment for my disease, the gluten-free diet, is inadequate and leaves millions of Americans suffering needlessly. I live in constant fear, knowing that ingesting just one tiny crumb of gluten will trigger debilitating illness and increase my risk of cancer, heart disease, and additional autoimmune disorders. Please support NIH funding for celiac disease research for fiscal year 2022 in order to develop new treatments, find a cure, and help improve the lives of patients like me. In the Advocacy Toolkit at iadvocate.celiac.org, you will find resources including how to set up meetings with your legislators, where you'll find information about your legislators, review our sample script for requesting a meeting, and make the most out of your interactions with members of Congress. You can meet with your members of Congress by calling, emailing, setting up an appointment at one of their district offices, or attending a town hall meeting or other public event. During the COVID-19 pandemic, members of Congress and their staff may also be offering virtual meetings. If your congressional meeting ends up being with a staff member rather than the member of Congress themselves, continue to treat the meeting with the same level of importance you would give to a member of Congress. Staff are often the people members of Congress turn to for advice, making them extremely important in guiding policy decisions. When advocating to members of Congress, it is important to clearly explain the action you would like them to take, the asks. This may seem obvious, but many legislators have said it can be frustrating to meet with constituents who don't know what they're looking for. Remember to tell your celiac story to explain why our asks for 2021 are important to you as someone with celiac disease. Sending a thank you note after your congressional meeting to express your gratitude can help build a professional relationship. See our legislative meeting thank you note template in the Advocacy Toolkit for an example of an effective thank you note. After your congressional meeting, it's important to keep in touch with the member of Congress and their staff through emails, visits, appointments, and letters to keep celiac disease issues on their mind. Look for positive ways to engage your members of Congress, such as tagging them in social media posts about celiac disease or sharing Celiac Disease Foundation emails with them to show how research is improving the lives of people with celiac disease. One of the simplest steps you can take as a state advocacy ambassador is to email your congressional representatives using the Celiac Disease Foundation's Take Action Center on celiac.org. Under the Get Involved menu, click Contact Your Members of Congress or use the URL celiac.org/takeaction, and you'll find a pre-written email that you can personalize for each of our current asks of Congress. When you enter your voting address, our advocacy software will display your representatives and email them on your behalf and allow you to share with your networks through social media and email. One of your most powerful advocacy tools is something you might already use every day. Social media is one of the most effective and efficient ways to spread awareness of celiac disease to your network. Our social media toolkit contains sample posts with important facts about celiac disease that you can use to educate your followers. Remember to tag the Celiac Disease Foundation in your advocacy posts and like and follow us on social media. If you have completed all the polls, including the one after this presentation, on March 23rd, you'll receive an email asking you to sign up to be a state advocacy ambassador at iadvocate.celiac.org. Once you have signed up and created your username and password, you'll be able to log in and download your Celiac Disease Foundation State Advocacy Ambassador Certificate. Under the Resources tab, you'll find the Advocacy Toolkit, the Celiac Disease Foundation State Advocate Forum, and the Advocacy Action Calendar. The Advocacy Toolkit contains the resources you need to meet with your members of Congress as a CDF State Advocacy Ambassador. The Celiac Disease Foundation State Advocate Forum will connect you with like-minded celiac disease advocates to build your network and share ideas. The Advocacy Action Calendar provides you with monthly ideas on how you and your networks can easily advocate. When you receive your email to sign up to be a state advocacy ambassador, complete your address information. Be sure that the box that says, "To become a state advocacy ambassador, I agree to receive Celiac Disease Foundation emails," is checked before clicking sign up. Once you sign up, you'll receive an email to create your iadvocate.celiac.org login ID and password. Under the Resources tab, you will find everything you need to ensure your success as a state advocacy ambassador. You will also have access to the online training program videos and slides from this presentation if you need a refresher. Once a month, we'll send you action alerts, training opportunities, and ways you can support the Celiac Disease Foundation's mission to accelerate diagnosis, treatments, and a cure for celiac disease. This calendar contains action items that coincide with the legislative calendar to strengthen your advocacy efforts. Here are some of the ways you can show your support. The biggest obstacle in getting a celiac drug to market is recruiting enough patients to participate in clinical trials. Share our Participate in Research page at celiac.org/participate-in-research with your network. Share Foundation social media posts and our monthly e-newsletter to promote awareness of celiac disease as a serious autoimmune disease. Check the Eat Gluten-Free app for the latest news on all things celiac. Call or email your members of Congress and their staff on a regular basis to stay in touch and build a relationship over time. Each month, we'll feature an advocacy ambassador in action. We encourage you to share your experiences and pictures with us so that we can follow up in Washington, D.C. on your state activities. We also provide you hotline support and welcome your emails and calls. Once you have signed up and logged into iadvocate.celiac.org, you'll be granted access to the iAdvocate Forum, a place where celiac disease advocates from all 50 states can collaborate, share advocacy experiences, and plan meetups with other advocates. All forum users must read the terms of use carefully to ensure this space remains inclusive, contains accurate information, and is free from personal promotions. Please join the forum and introduce yourself. Click on the topic threads for specific policy priorities or the thread specific to your state or region to communicate with other celiac disease advocates in your area. State Advocacy Ambassador Kelsey Smith is our forum moderator. Kelsey moderates the forum by answering questions and posting prompts for advocacy ambassadors. You can introduce yourself to Kelsey in the forum, username Celiac Disease Foundation Moderator, and let her know what forum topics you'd like to see her post. To use the iAdvocate forum, click on the Introduce Yourself topic thread and introduce yourself and your connection to celiac disease. Use the NIH research topic to post activities and comments related to NIH funding for celiac disease research. To connect with other advocates in your own state, go to the forum for your state and start networking and planning your state advocacy efforts. To conclude this training, here's a checklist of the next steps you should take as a Celiac Disease Foundation Advocacy Ambassador. Complete the polls, and when your Celiac Disease Foundation State Advocacy Ambassador email is received, sign up at iadvocate.celiac.org and log in to receive your certificate. Join the iAdvocate forum and start connecting with other advocates near you to plan team meetups to visit members of Congress in your home state and share your efforts. Download the Eat Gluten-Free app to easily stay informed about our work in recent celiac disease research. Complete the monthly activities in the Advocacy Action Calendar to continue your important advocacy work. Educate your network about celiac disease using posts from our social media toolkit. Send pictures you take with your members of Congress and tell us how your meeting went by emailing sierra.manning@celiac.org. And lastly, attend the annual Patient Education and Advocacy Summit every year. Thank you for attending the Patient Education and Advocacy Summit. Remember to successfully complete the poll that follows this video to become a State Advocacy Ambassador. Submit any questions you have for the Q&A in the chat box. We'll get to as many questions as time allows. Details regarding the $25 gluten-free lunch reimbursement will be emailed to your registration email address for participants who completed all polls. Thank you for joining the Celiac Disease Foundation State Advocacy Ambassador Network. We look forward to working with you to advocate for a better future for all celiac disease patients.
So at this time, I would like to invite our Director of Research and Advocacy, Julia Macbeth, our Coordinator of Research and Advocacy, Sierra Manning, who I have to give a huge shout out because all today was all Sierra, and we are deeply thankful for her efforts. And then Sheila Burke and Mark Vandewater from Baker Donaldson. So a couple of questions have come up while you're completing your last poll. And I think the most important one, and I'll go ahead and answer it myself, is how much time do I have to commit to be a state advocacy ambassador? And the answer to that question, and I'm sorry, I just have a cat that just bit me. Welcome to Zoom, is that it's as much time as you'd actually like. So, if posting on social media is your thing, and we will have in our advocacy toolkit social media posts that you can create and post to whatever your favorite form of social media is. If it's simply clicking a button to submit an email, or if it's really taking that next step and setting up meetings with your congressional representatives. It's whatever you want to do. And we have the team here. You see their faces on the screen who would love to get you started in whatever direction you want to go. So the next question that I had was regarding the $12 million that was requested for the CDMRP budget. And the question was, what would that $12 million do? What that $12 million is for researchers to apply for grants to help solve the problem. So in addition to NIH funding and those monies that would help our researchers, they could also apply to research for research dollars under these programs as well. And then of course we would want cross collaboration between the sets of researchers so that we're all working on the same issues together. And Sheila and Mark, did you want to add anything more about the Congressional Research Dollars Program? Sheila, you are on mute.
I got it. No, I think you've described it correctly. This is an area we hadn't focused on in our prior efforts, but one that's come to our attention, one that we believe would warrant the kind of research and investment around this particular population. But I think you've described it correctly.
Okay. The next question is regarding the federal level, and we've talked all about today at the federal level. Can these efforts be duplicated at the state and local level? And if so, what would that look like?
Well, Marilyn, I'll give an initial response, but there are others. I mean, one of the things that was evident in the course of our conversations today is there is an enormous amount of work that also takes place at the state level. Admittedly, big funds tend to come through federal resources. But certainly the states are increasingly interested in these issues, their legislatures, in terms of the requirements for restaurants and others in their communities. So keeping informed your state legislators as well, I think is critically important. Opportunities for education campaigns, what occurs with respect to schools, much of which occurs at the state and local level rather than at a federal level. So I think there are opportunities there as well. And I think some of our colleagues who spoke today and some of the advisors in the introductory section to this discussion talked as well about sort of local activities as well as federal.
The next question we have is, should we be encouraging our representatives to join the Celiac Caucus now?
Yes, absolutely. I mean, it's newly formed. We will, I think, in Marilyn's efforts and the efforts of her team, help provide you with information. But our goal is to get as many members on that caucus as absolutely possible. It indicates interest, it indicates support. It's often referenced in our efforts to increase funding, for example, through appropriations. So it's a sign that this is an issue that has risen in terms of its importance and the number of members that are essentially participating. Staff become aware of this is enormously important. So we are very anxious for you to contact your delegations. And it doesn't require anything on the part of the member unless they choose to. You're not asking them for a particular effort, but rather simply joining the caucus. It will allow them to be informed and it will make us available and aware of the issues that they're concerned about and provides an opportunity for us to contact and work with them.
All right, we have a couple of very specific questions. We have residents in Washington, D.C. who want to know how they can advocate if their particular representatives don't have a vote. Can you explain how that works in D.C. to those of us who don't know?
Sure. An issue of some interest, as you might imagine, the people that live in DC and don't have a senator or representative. I mean, you do have a delegate, Eleanor Holmes Norton in the House, who's quite outspoken, very engaged. and notwithstanding not having essentially the same standing as other members, doesn't let that limit her engagement at all. So you ought to certainly feel free to talk with her, to reach out to her, to reach out to her office. But also think about where you're from. I mean, there aren't many people from the district. I mean, you know, we're all sort of from someplace else with rare exception. And if you need to, you know, go to somebody who essentially has a relationship to where you're from, where your family are from, where you grew up. You know, it's creating that connection back to sort of their constituency. So don't be in the least bit concerned if you live here. And if you do, and you're literally from the district, don't hesitate to call and contact Ellen Holmes Norton, but also don't hesitate to call or go back to, you know, wherever you're from and contact that legislator, or where your parents are from, or where you grew up, whatever it happens to be.
All right, we have another very specific question. I am a federal employee and we have limitations on our political activity due to the Hatch Act. So do you have federal employees serving as advocates, and what do they do regarding the Hatch Act?
I don't know the answer to that question. I mean, we don't necessarily know what the affiliation is of individuals who've chosen to be advocates, but it's certainly you're not campaigning for someone, you're not using federal resources in that context. You're involved in issues and in questions that are of a personal nature to you. You would have to be careful in terms of how you did that and what resources you used. But you're essentially, you know, not asking for in support of a member, you're talking about an issue.
Terrific. So the next question is regarding joining the caucus. Will there be a template for asking the Congress people to join? And I'm going to presume that the answer is yes, since the caucus was just newly launched. We will, actually, we have several meetings tomorrow regarding this, so that we will be putting out information to the community about exactly how to ask their Congress people for that. Correct? Okay, good. The other question that was raised was, what if somebody did not attend the training? Am I able as an advocacy ambassador to share what I've learned with them so they can help advocate with me? And Julie and Sierra, would you like to take that?
Yeah, so if you do complete the training, the main things you gain are access to all of our resources on our website. So it really just makes it a lot easier for you and gives you all of the tools you need. You get all the leave behinds, information on how to get in contact with your representatives. And that being said, anybody can participate in advocacy. But one of the major reasons why we want to have a unified front on this is just so that we can make sure that the asks we're presenting to Congress are a few achievable policy priorities that we know will get passed, and that we just really have a unified front. So that's why we're asking people to complete this training. But that being said, anybody can contact their members of Congress.
All right, so we have another specific question. I am an employee of a pharmaceutical company, though we have no celiac disease drugs. Does this preclude me from advocating?
No, absolutely not. Absolutely not. I mean, you're advocating not on the part of your company or on the part of something they might do. You're advocating specifically on your own behalf with respect to a specific condition. So no, I wouldn't let that pause any of your activities.
All right, so then we have a question about somebody who's not been officially diagnosed with celiac disease, and can they be an advocate? So there are a large number of us who put ourselves on a gluten-free diet because we had symptoms and our physicians refused to test us. There are physicians who have simply told us, go on a gluten-free diet and see if it works, who've not ordered a blood test. There are another group of us who've had a blood test and not an endoscopy. So while some of these events would disqualify you from participating in clinical trial, none of these disqualify you from advocating on behalf of the celiac community. I do not have celiac disease. My son and his father both have celiac disease. I consider myself to be an advocate. So if you have anybody that you know or love, it doesn't matter your own personal diagnosis. And certainly if you think you have celiac disease, it's your story to share. You can share the reason why you don't know if you're diagnosed, that your physician wouldn't test you, that you had to put yourself on the gluten-free diet because nobody would listen to you despite your family member having it or the symptoms you've had or whatever your experience is. So yes, we welcome everybody to advocate. There are no limitations. Well, I see that the answers to the last poll have popped up. And I also see that we don't have any additional questions. So at this point, I'm going to say, for those of you who are not able to complete the 4 polls, do not worry. You can email Sierra Manning. Her email is in the chat box, and let her know. But for those of you who have completed today, you will be receiving an email on March 23rd with your instructions on how to log into the advocacy website. You'll be able to get your certificate and all of these tools. And we have everybody's email. So again, whether you completed no polls today or 4 polls, everybody can participate in our email campaigns to Congress. So I'm going to say thank you so much for today. I want to thank again all of our speakers, our panelists, our advocacy council, our wonderful staff, the volunteers, our sponsors, and you. You are the heart and soul of the celiac community, and you are the reason why Congress is beginning to take celiac disease seriously. So we look forward to all of your efforts and to seeing you again next year. Thank you.